with, but it does not imply or exclude a genetic basis for the birth defect. It is estimated that about 120,000, 1 in 33, babies are born with a birth defect each year in the United States. In a sense, anomalies found in live-born infants represent the less serious developmental failures in embryogenesis as they are compatible with live birth. Perhaps 20% of fertilized ova are so anomalous that they are blighted at early stages. Others may be compatible with early fetal development, only to 4 Chap-ter 5410 of infancy and childhood. Figure 10.1 Examples of malformations. A. Polydactyly, one or more extra digits, and syndactyly, fusion of digits, have little functional consequence when they occur in isolation. Similarly, cleft lip B with or without associated cleft palate is compatible with life when it occurs as an isolated anomaly. In the present case, however, this neonate had an underlying malformation syndrome, trisomy 13, and died of severe cardiac defects. C. The stillbirth illustrated represents a severe and essentially lethal malformation, wherein the midface structures are fused or ill-formed. In almost all cases, this degree of external dysmorphogenesis is associated with severe internal anomalies such as maldevelopment of the brain and cardiac defects. A and C. Courtesy Dr. Reed Quinton, B. Lead to spontaneous abortion. Less severe anomalies allow more prolonged intrauterine survival, with some disorders terminating in stillbirth and those still less significant permitting live birth despite the handicaps imposed. Definitions. The process of morphogenesis, organ and tissue development, can be impaired by a variety of different errors. Malformations represent primary errors of morphogenesis, in which there is an intrinsically abnormal developmental process, Fig. 10.1. Malformations can be the result of a single gene or chromosomal defect, but are more commonly multifactorial in origin. Developmental anomalies may present in several patterns. Some, such as congenital heart defects and anencephaly, absence of part or all of the brain, involve single body systems, whereas in other cases multiple malformations involving many organs may coexist. Disruptions result from secondary destruction of an organ or body region that was previously normal in development. Thus, in contrast with malformations, disruptions arise from an extrinsic disturbance in morphogenesis. Amniotic bands, denoting rupture of amnion with resultant formation of bands that encircle, compress, or attach to parts of the developing fetus, are the classic example of a disruption. Fig. 10.2. A variety of environmental agents may cause disruptions, see later. Disruptions are not heritable, hence they are not associated with increased risk of recurrence in subsequent pregnancies. Deformations, like disruptions, represent an extrinsic disturbance of development rather than an intrinsic error of morphogenesis. Deformations are common problems, affecting approximately 2% of newborn infants. To varying degrees, fundamental to the pathogenesis of deformations is localized or generalized compression of the growing fetus by abnormal biomechanical forces, leading eventually to a variety of structural abnormalities. The most common underlying factor responsible for deformations is uterine constraint. Between 35 and 38 weeks of gestation, rapid increase in the size of the fetus outpaces the growth of the uterus, and the relative amount of amniotic fluid, which normally acts as a cushion, decreases. Thus, even the normal fetus is subjected to some degree of uterine constraint. Several factors increase. Figure 10.2 Disruption of morphogenesis by an amniotic band. Note the placenta at the right of the diagram and the band of amnion extending from the top portion of the amniotic sac to encircle the leg of the fetus. Courtesy Dr. Theonia Boyd, Boston Children's Hospital, Boston, Massachusetts. Diseases. Congenital anomala 545IEs. The likelihood of excessive compression of the fetus resulting in deformations. Maternal factors include first pregnancy, small uterus, malformed e.g., bicornuate uterus, and leiomyomas. Fetal or placental factors include oligohydramnios, multiple fetuses, and abnormal fetal presentation. For example, clubfeet can occur as a component of Potter sequence, described later. A sequence is a cascade of anomalies triggered by one initiating aberration. Approximately one-half the time, congenital anomalies occur singly. In the remaining cases, multiple congenital anomalies are recognized. In some instances, the constellation of anomalies may be explained by a single localized aberration in organogenesis, malformation, disruption, or deformation that sets into motion secondary effects in other organs. A good example is the oligohydramnios or Potter sequence. Fig. 10.3. Oligohydramnios, decreased amniotic fluid, may be caused by a variety of unrelated maternal, placental, or fetal abnormalities. The most common cause of oligohydramnios is chronic leakage of amniotic fluid due to rupture of fetal membranes. Other causes include renal agenesis and urinary tract obstruction in the fetus because fetal urine is a major constituent of amniotic fluid, and uteroplacental insufficiency resulting from maternal hypertension or severe preeclampsia. The fetal compression associated with significant oligohydramnios, in turn, results in a classic phenotype in the newborn infant, including flattened facies, positional abnormalities of the hands, and clubfeet. Fig. 10.4. The hips may be dislocated. Growth of the chest wall and the contained lungs is also compromised so that the lungs are frequently hypoplastic and may cause fetal demise. Nodules in the amnion nodosum are frequently present. A malformation syndrome is a constellation of congenital anomalies, believed to be pathologically related, that, in contrast to a sequence, cannot be explained on the basis of a single, localized, initiating defect. Syndromes are most often caused by a single etiologic agent, such as a viral infection or specific chromosomal abnormality, which simultaneously affects several tissues. In addition to the aforementioned general definitions, a few organ-specific terms should be defined. Agenesis refers to the complete absence of an organ and its associated. Figure 10.4 Infant with oligohydramnios sequence. Note the flattened facial features and deformed right foot talipes echinovarus primordium. A closely related term, aplasia, also refers to the absence of an organ but one that occurs due to failure of growth of the existing primordium. Atresia describes the absence of an opening, usually of a hollow visceral organ, such as the trachea or intestine. Hypoplasia refers to incomplete development or decreased size of an organ with decreased numbers of cells, whereas hyperplasia refers to the converse, that is, the enlargement of an organ due to increased numbers of cells. An abnormality in an organ or a tissue as a result of an increase or a decrease in the size rather than the number of individual cells defines hypertrophy or hypertrophy, respectively. Finally, dysplasia in the context of malformations versus neoplasia describes an abnormal organization of cells causes of anomalies. Amnion nodosum, pulmonary hypoplasia. Renal agenesis, altered facies. Figure 10.3 Schematic diagram of the amniotic leak, oligohydramnios, fetal compression, positioning defects of feet, hands. Others. Breech presentation. Although we are learning a great deal about the molecular basis of some congenital anomalies, the exact cause remains unknown in 40% to 60% of cases. The era of molecular medicine promises to bring additional insights into the mechanisms by which malformations occur. The common known causes of congenital anomalies can be grouped into three major categories: genetic, environmental, and multifactorial. Table 10.1. Genetic causes of malformations include all of the previously discussed mechanisms of genetic disease. Chapter 5. Virtually all chromosomal syndromes are associated with congenital malformations. Examples include Down syndrome and other trisomies, Turner syndrome, and Klinefelter syndrome. Most chromosomal disorders arise during gametogenesis and hence are not familial. Single gene 456. Chapter 10 Diseases of infancy and childhood. 1N live born 0. 1 IFAN causes TS of congenital anomalies I. Cause frequency % genetic chromosomal aberrations. Cytomegalovirus. Endocrinopathy. Folic acid. Mutations, characterized by Mendelian inheritance, may underlie some major malformations. For example, holoprosencephaly is the most common developmental defect of the forebrain and midface in humans. The hedgehog signaling pathway plays a critical role in the morphogenesis of these structures, and loss of function mutations of individual components within this pathway are reported in families with a history of recurrent holoprosencephaly. Environmental influences, such as viral infections, drugs, and maternal irradiation, may cause fetal anomalies. Among the viral infections listed in Table 10.1, rubella was a major scourge of the 19th and early 20th centuries. Fortunately, maternal rubella and the resultant rubella embryopathy have been virtually eliminated in high-income countries as a result of maternal rubella vaccination. A variety of drugs and chemicals have been suspected to be teratogenic, but perhaps less than 1% of congenital malformations are caused by these agents. The list includes thalidomide, alcohol, anticonvulsants, warfarin oral anticoagulant, and 13-cisretinoic acid, which is used in the treatment of severe acne. For example, thalidomide, once used as a tranquilizer in Europe, causes an extremely high incidence 50% to 80% of limb malformations. Alcohol, when consumed even in modest amounts during pregnancy, is an important environmental teratogen. Affected infants show prenatal and postnatal growth restriction, facial anomalies, microcephaly, short palpebral fissures, maxillary hypoplasia, and psychomotor disturbances. These in combination are labeled the fetal alcohol syndrome, also discussed in Chapter 9. Although cigarette smoke-derived nicotine has not been convincingly demonstrated to be a teratogen, there is a high incidence of spontaneous abortion, premature labor, and placental abnormalities in pregnant women who smoke. Babies born to mothers who smoke often have a low birth weight and may be prone to sudden infant death syndrome, discussed later. In light of these findings, it is best to avoid nicotine exposure altogether during pregnancy. Among maternal conditions listed in Table 10.1, diabetes mellitus is a common entity, and despite advances in antenatal obstetric monitoring and glucose control, the incidence of major malformations in infants of diabetic mothers stands between 6% and 10% in most series. Maternal hyperglycemia-induced fetal hyperinsulinemia results in fetal macrosomia, organomegaly and increased body fat and muscle mass. Cardiac anomalies, neural tube defects, and other central nervous system (CNS) malformations are some of the major anomalies seen in diabetic embryopathy. Multifactorial inheritance, which implies the interaction of environmental influences with two or more genes of small effect, is the most common genetic etiology of congenital malformations. Examples include relatively common malformations such as cleft lip, cleft palate, and neural tube defects. The dramatic reduction in incidence of neural tube defects by periconceptional intake of folic acid is one case where understanding the environmental stimuli has prevented development of multifactorial malformations even though contributing genes have not been eliminated. Pathogenesis. The pathogenesis of congenital anomalies is complex and still poorly understood, but two general principles of developmental pathology are relevant regardless of the etiologic agent. 1. The timing of the prenatal teratogenic insult has an important impact on the occurrence and the type of anomaly produced. Fig. 10.5. The intrauterine development of humans can be divided into two phases. 1. The early embryonic period occupying the first 9 weeks of pregnancy, and 2. The fetal period terminating at birth. In the early embryonic period, first 3 weeks after fertilization, an injurious agent damages either enough cells to cause death and abortion or only a few cells, presumably allowing the embryo to recover without developing defects. Between the 3rd and the 9th weeks, the embryo is extremely susceptible to teratogenesis. Peak sensitivity occurs between the 4th and the 5th weeks. During this period, organs are being crafted out of the germ cell layers. The fetal period that follows organogenesis is marked chiefly by further growth and maturation of the organs, with greatly reduced susceptibility to teratogenic agents. Instead, the fetus is susceptible to growth restriction or injury to already formed organs. Thus, a given agent may produce different anomalies if exposure occurs at different times of gestation. 2. The interplay between environmental teratogens and intrinsic genetic defects is exemplified by the fact that features of dysmorphogenesis caused by environmental insults can often be recapitulated by genetic defects in and fetal growth restriction. 450. Embryonic period. 1. Marula. Usually Ta. Low set mal. The pathways targeted by these teratogens. This is illustrated by the following representative examples. Cyclopamine is a plant teratogen contained in the corn lily. Pregnant sheep who feed on this plant give birth to lambs with severe craniofacial abnormalities including holoprosencephaly and cyclopia, single-fused eye, hence the origin of the moniker cyclopamine. This compound is an inhibitor of hedgehog signaling in the embryo, and, as stated earlier, mutations of hedgehog genes are present in subsets of patients with holoprosencephaly. Valproic acid is an antiepileptic and a recognized teratogen during pregnancy. Valproic acid disrupts expression of a family of highly conserved developmentally critical transcription factors known as hox proteins. In vertebrates, Hox proteins have been implicated in the patterning of limbs, vertebrae, and craniofacial structures. Not surprisingly, mutations in the Hox family of genes are responsible for congenital anomalies that mimic features observed in valproic acid embryopathy. The vitamin A retinol derivative all-trans-retinoic acid is essential for normal development and differentiation, and its absence during embryogenesis results in a constellation of malformations affecting multiple organ systems, including the eyes, genitourinary system, cardiovascular system, diaphragm, and lungs. See Chapter 9 for effects of vitamin A deficiency in the postnatal period. Conversely, excessive exposure to retinoic acid is also teratogenic. Infants born to mothers treated with retinoic acid for severe acne have a predictable phenotype, retinoic acid embryopathy, including CNS, cardiac, and craniofacial defects, such as cleft lip and cleft palate. The latter may stem from retinoic acid-mediated deregulation of components of the transforming growth factor beta, TGF-beta, signaling pathway, which is involved in polytogenesis. Mice with knockout of the TGFB3 gene uniformly develop cleft palate, once again illustrating the functional relationship between teratogenic exposure and signaling pathways in the causation of congenital anomalies. Prematurity and fetal growth restriction. Prematurity, defined by a gestational age less than 37 weeks, is the second most common cause of neonatal mortality, behind only congenital anomalies. The Centers for Disease Control and Prevention (CDC), cdc.gov/reproductive health, report that in 2016, preterm birth affected about 1 in 10 infants born in the United States. Preterm birth rates decreased from 2007 to 2014 due, in part, to declines in the number of births to teens and young mothers. However, the rate among African American women, 14%, remains greater than that in white women, 9%. The major risk factors for prematurity include the following. 458 Chapter 10 Diseases of Infancy and Childhood. Preterm premature rupture of membranes PPROM. PPROM complicates about 3% of all pregnancies and is responsible for as many as 1/3 of all preterm deliveries. Rupture of membranes ROM before the onset of labor can be spontaneous or induced. PPROM refers to spontaneous ROM occurring before 37 weeks of gestation, hence the annotation, preterm. In contrast, PROM refers to spontaneous ROM occurring after 37 weeks of gestation. This distinction is important because after 37 weeks the associated risk to the fetus is considerably decreased. Several clinical risk factors have been identified for PPROM, including a prior history of preterm delivery, preterm labor and/or vaginal bleeding during the current pregnancy, maternal smoking, low socioeconomic status, and poor maternal nutrition. The fetal and maternal outcome after PPROM depends on the gestational age of the fetus. Second trimester PPROM has a dismal prognosis and the effective prophylaxis of infections in the exposed amniotic cavity. Intrauterine infection. This is a major cause of preterm labor with and without intact membranes. Intrauterine infection is present in approximately 25% of all preterm births, and the earlier the gestational age at delivery, the higher the frequency of intraamniotic infection. The histologic correlates of intrauterine infection are inflammation of the placental membranes chorioamnionitis and inflammation of the fetal umbilical cord funisitis. The most common microorganisms implicated in intrauterine infections leading to preterm labor are Uriplasma ureolyticum, Mycoplasma hominis, Gardnerella vaginalis, the dominant organism found in bacterial vaginosis, a polymicrobial infection, trichomonas, gonorrhea, and chlamydia. In low-income countries, malaria and HIV are significant contributors to the burden of preterm labor and prematurity. Recent studies have begun to elucidate the molecular mechanisms of inflammation-induced preterm labor. Endogenous toll-like receptors TLRs, which bind bacterial components as natural ligands, Chapter 6, have emerged as key players in this process. It is postulated that signals produced by TLR engagement deregulate prostaglandin expression, which, in turn, induces uterine smooth muscle contractions. Uterine, cervical, and placental structural abnormalities. Uterine distortion e.g., uterine fibroids, compromised structural support of the cervix, cervical incompetence, placenta previa, and abruptio placentae, Chapter 22, are associated with an increased risk of prematurity. Multiple gestation, twin pregnancy. The hazards of prematurity are manifold for the newborn and may give rise to one or more of the following. Neonatal respiratory distress syndrome, also known as hyaline membrane disease. Necrotizing enterocolitis (NEC), sepsis, intraventricular and germinal matrix hemorrhage. Fetal growth restriction. Although preterm infants have low birth weights, it is usually appropriate once adjusted for their gestational age. In contrast, as many as 1/3 of infants who weigh less than 2,500 grams are born at term and are therefore underground rather than immature. These small for gestational age (SGA) infants suffer from fetal growth restriction (FGR), which may result from maternal, fetal, or placental abnormalities, although in many cases the specific cause is unknown. Maternal abnormalities. By far the most common factors associated with SGA infants are maternal conditions that result in decreased placental blood flow. Vascular diseases such as preeclampsia, toxemia of pregnancy, and chronic hypertension are often the underlying cause. The list of other maternal conditions associated with SGA infants is long, but some of the avoidable factors worth mentioning are maternal narcotic abuse, alcohol intake, and heavy cigarette smoking. Drugs causing FGR include both classic teratogens, such as chemotherapeutic agents, and some commonly administered therapeutic agents, such as phenytoin dilantin. Maternal malnutrition, in particular, prolonged hypoglycemia, may also affect fetal growth. Fetal abnormalities. Fetal influences are those that intrinsically reduce growth potential of the fetus despite an adequate supply of nutrients from the mother. Prominent among such fetal conditions are chromosomal disorders, congenital anomalies, and congenital infections. Chromosomal abnormalities may be detected in up to 17% of fetuses sampled for FGR and in up to 66% of fetuses with documented ultrasonographic malformations. Among the first group, the abnormalities include triploidy, 7%, trisomy 18, 6%, trisomy 21, 1%, trisomy 13, 1%, and a variety of deletions and translocations, 2%. Fetal infection should be considered in all infants with FGR. Those most commonly responsible for FGR are the TORCH group of infections, toxoplasmosis, other viruses and bacteria such as syphilis, rubella, cytomegalovirus, and herpes virus. Infants who are SGA because of fetal factors usually have symmetric growth restriction, also referred to as proportionate FGR, meaning that all organ systems are similarly affected. Placental abnormalities. During the third trimester of pregnancy, vigorous fetal growth places particularly heavy demands on the uteroplacental blood supply. Therefore, the adequacy of placental growth in the preceding mid-trimester is extremely important, and uteroplacental insufficiency is an important cause of growth restriction. This insufficiency may result from umbilical placental vascular anomalies such as single umbilical artery and abnormal cord insertion, placental abruption, placenta previa, placental thrombosis and infarction, chronic villus of unknown etiology, placental infection, or multiple gestations. Chapter 22. In some cases the placenta and the baby may be small without any detectable underlying cause. Placental causes of FGR tend to result in asymmetric or disproportionate growth restriction of the fetus with relative sparing of the brain. Physiologically, this general type of FGR is viewed as a downregulation of growth in the latter half of gestation because of limited availability of nutrients or oxygen. The SGA infant faces a difficult course, not only during the struggle for survival in the perinatal period, but also in prematurity and fetal growth restriction 459. Childhood and adult life. Depending on the underlying cause of FGR and, to a lesser extent, the degree of prematurity, there is a significant risk of morbidity in the form of a major handicap such as cerebral dysfunction, learning disability, or hearing and visual impairment. Neonatal respiratory distress syndrome. There are many causes of respiratory distress in the newborn. The most common cause is neonatal respiratory distress syndrome, RDS, also known as hyaline membrane disease because of the deposition of a layer of hyaline proteinaceous material in the peripheral air spaces of infants who succumb to this condition. Others include excessive sedation of the mother, fetal head injury during delivery, aspiration of blood or amniotic fluid, and intrauterine hypoxia brought about by coiling of the umbilical cord about the neck. The incidence of RDS increases with decreasing gestational age, being 1% at 37 weeks, 10.5% at 34 weeks, and 93% in extremely preterm infants 28 weeks or below. Pathogenesis. The fundamental defect in RDS is pulmonary immaturity and deficiency of surfactant. As described in Chapter 15, surfactant consists predominantly of dipalmitoyl phosphatidylcholine, lecithin, smaller amounts of phosphatidyl L-glycerol, and two groups of surfactant-associated proteins. The first group is composed of hydrophilic glycoproteins SPA and SPD, which play a role in pulmonary host defense and innate immunity. The second group consists of hydrophobic surfactant proteins SPB and SPC, which, in concert with the surfactant lipids, are involved in the reduction of surface tension at the air-liquid barrier in the alveoli of the lung. With reduced surface tension in the alveoli, less pressure is required to keep them patent and hence aerated. The importance of surfactant proteins in normal lung function can be gauged by the occurrence of severe respiratory failure in neonates with congenital deficiency of surfactant caused by mutations in the SFTPB or SFTPC genes. Surfactant production by type II alveolar cells is accelerated after the 35th week of gestation in the fetus. At birth, the first breath of life requires high inspiratory pressures to expand the lungs. With normal levels of surfactant, the lungs retain up to 40% of the residual air volume after the first breath, thus, subsequent breaths require far lower inspiratory pressures. With a deficiency of surfactant, the lungs collapse with each successive breath, so infants must work as hard with each successive breath as they did with the first. The problem of stiff atelectatic lungs is compounded by the soft thoracic wall that is pulled in as the diaphragm descends. Progressive atelectasis and reduced lung compliance then lead to a chain of events as depicted in Fig. 10.6, resulting in protein-rich, fibrin-rich exudation into the alveolar spaces with the formation of hyaline membranes. The fibrin-hyaline membranes are barriers to gas exchange, leading to carbon dioxide retention and hypoxemia. The hypoxemia itself further impairs surfactant synthesis, and a vicious cycle ensues. Surfactant synthesis is modulated by a variety of hormones and growth factors, including cortisol, insulin, prolactin, thyroxine, and TGF-beta. The role of glucocorticoids is particularly important. Conditions associated with prematurity, reduced surfactant synthesis, storage, and release, decreased alveolar surfactant, uneven perfusion, hypoxia, acid, intrauterine stress and FGR that increase corticosteroid release lower the risk of developing RDS. Surfactant synthesis can be suppressed by the compensatory high blood levels of insulin in infants of diabetic mothers, which counteracts the effects of steroids. This may explain, in part, why infants of diabetic mothers have a higher risk of developing RDS. Labor is known to increase surfactant synthesis, hence, cesarean delivery before the onset of labor may increase the risk of RDS. Morphology. The lungs are distinctive on gross examination. Though of normal size, they are solid, airless, and reddish-purple, similar to the color of the liver, and they usually sink in water, indicating the relative absence of entrapped air. Microscopically, alveoli are poorly developed, and those that are present are collapsed. Fig. 10.7. When the infant dies early in the course of the disease, necrotic cellular debris can be seen in the terminal bronchioles and alveolar ducts. The necrotic material becomes incorporated within eosinophilic hyaline membranes lining the respiratory bronchioles, alveolar ducts, and alveoli. The membranes are largely made up of fibrin admixed with cell debris derived chiefly from necrotic type II pneumocytes. The sequence of events that leads to the formation of hyaline membranes is depicted in Fig. 10.6. Chapter 10 Diseases of Infancy and Childhood. Figure 10.7 Hyaline membrane disease. There are eosinophilic thick hyaline membranes lining the dilated alveoli. Note that the remaining airspaces are lined by cuboidal epithelium, arrow indicating immaturity of the lung. There is a remarkable paucity of neutrophilic inflammatory reaction associated with these membranes. The lesions of hyaline membrane disease are never seen in stillborn infants. In infants who survive more than 48 hours, progressive reparative changes occur in the lungs. The alveolar epithelium proliferates under the surface of the membrane, which may detach into the airspace where it undergoes partial digestion or phagocytosis by macrophages. If it does not detach, Fibroblasts grow into the membrane, and it becomes incorporated into the alveolar wall. 460. Clinical features: the infant is almost always preterm but has weight appropriate for gestational age, and there are strong but not invariable associations with male gender, maternal diabetes, and cesarean delivery. Resuscitation may be necessary at birth, but usually within a few minutes rhythmic breathing and normal color are reestablished. Soon afterward, often within 30 minutes, breathing becomes more difficult, and within a few hours cyanosis becomes evident in the untreated infant. Fine rales can then be heard over both lung fields. A chest radiograph at this time usually reveals uniform minute reticulogranular densities, producing a so-called ground glass picture. In the full-blown condition, the respiratory distress persists, cyanosis increases, and even the administration of 80% oxygen by a variety of ventilatory methods fails to improve the situation. If therapy staves off death for the first 3 or 4 days, however, the infant has an excellent chance of recovery. Currently, the actual clinical course and prognosis for neonatal RDS vary, depending on the maturity and birth weight of the infant and the promptness of institution of therapy. A major thrust in the control of RDS focuses on prevention, either by delaying labor until the fetal lung reaches maturity or by inducing maturation of the lung in the at-risk fetus by use of antenatal steroids. Critical to these objectives is the ability to assess fetal lung maturity accurately. Because pulmonary secretions are discharged into the amniotic fluid, analysis of amniotic fluid phospholipids provides a good estimate of the level of surfactant in the alveolar lining. Prophylactic administration of exogenous surfactant at birth to extremely premature infants, gestational age less than 28 weeks, has been shown to be very beneficial. Together with newer assisted ventilation techniques, this has resulted in dramatic improvement in pulmonary function, symptom resolution, a shortened course, and markedly reduced mortality. In uncomplicated cases, recovery begins to occur within 3 or 4 days. Complications of RDS, retrolental fibroplasia, also called retinopathy of prematurity, in the eyes, and bronchopulmonary dysplasia are now less frequent and less severe when they do occur. Retinopathy of prematurity has a 2-phase pathogenesis. During the hyperoxic phase of RDS therapy, phase 1, expression of the proangiogenic vascular endothelial growth factor, VEGF, is markedly decreased, causing endothelial cell apoptosis. VEGF levels rebound after return to relatively hypoxic room air ventilation. Phase 2, inducing retinal vessel proliferation, neovascularization, characteristic of the lesions in the retina, chapter 29. Bronchopulmonary dysplasia is characterized by striking decrease in alveolar septation, manifested as large, simplified alveolar structures and a dysmorphic capillary configuration. Thus, the current view is that bronchopulmonary dysplasia is caused by a potentially reversible impairment in the development of alveolar septation at the so-called saccular stage. Multiple factors, hyperoxemia, hyperventilation, prematurity, inflammatory cytokines, and vascular maldevelopment, contribute to bronchopulmonary dysplasia and probably act additively or synergistically to promote injury. The levels of a variety of pro-inflammatory cytokines TNF, interleukin-1 beta, IL-1 beta, IL-6, and IL-8 are increased in the alveoli of infants who develop bronchopulmonary dysplasia, suggesting a role for these cytokines in arresting pulmonary development. Treatment with mesenchymal stem cells has potential but remains experimental. They act by secreting soluble factors that suppress inflammation and favor repair of the air spaces. Infants who recover from RDS are also at increased risk for developing a variety of other complications associated with preterm birth. Most important among these are patent ductus arteriosus, intraventricular hemorrhage, and necrotizing enterocolitis. Necrotizing enterocolitis. Necrotizing enterocolitis (NEC) is most common in premature infants, with the incidence of the disease being inversely proportional to the gestational age. It occurs in approximately 1 in 10 very low birth weight infants, less than 1,500 grams. Approximately 2,500 cases occur annually in the United States. The pathogenesis of NEC is uncertain but multifactorial. In addition to prematurity, most cases are associated with enteral feeding, suggesting that some postnatal insult, such as introduction of bacteria, sets in motion a cascade of events culminating in tissue destruction. Although infectious agents may play a role in the pathogenesis of NEC, no single bacterial pathogen has been linked to the disease. Perhaps alteration in the microbiome on enteral feeding. Infections 461 plays a role. A large number of inflammatory mediators have been associated with NEC. One particular mediator, platelet activating factor (PAF), has been implicated in increasing mucosal permeability by promoting enterocyte apoptosis and compromising intercellular tight junctions, thus adding fuel to the fire. Stool and serum samples of infants with NEC demonstrate higher PAF levels than age-matched controls. Ultimately, breakdown of mucosal barrier functions permits transluminal migration of gut bacteria, leading to a vicious cycle of inflammation, mucosal necrosis, and further bacterial entry, eventually culminating in sepsis and shock, chapter 4. The clinical course is fairly typical, with the onset of bloody stools, abdominal distension, and development of circulatory collapse. Abdominal radiographs often demonstrate gas within the intestinal wall, pneumatosis intestinalis. When detected early, NEC often can be managed conservatively, but many cases 20% to 60% require resection of the necrotic segments of bowel. NEC is associated with high perinatal mortality, Those who survive often develop post-NEC strictures from fibrosis caused by the healing process. Probiotic therapies are being evaluated for prevention of NEC. Morphology. NEC typically involves the terminal ileum, cecum, and right colon, although any part of the small or large intestine may be involved. The involved segment is distended, friable, and congested, or it can be frankly gangrenous. Intestinal perforation with accompanying peritonitis may occur. Microscopically, mucosal or transmural coagulative necrosis, ulceration, bacterial colonization, and submucosal gas bubbles may be seen. Fig. 10.8. Reparative changes, such as the formation of granulation tissue and fibrosis, may begin shortly after the acute episode. Perinatal. Perinatal infections in general. Fetal and perinatal infections are acquired through one of two primary routes, transcervically also referred to as ascending or transplacentally hematologic. Occasionally, infections occur by a combination of the two routes in that an ascending microorganism infects the endometrium and then invades the fetal bloodstream via the chorionic villi. Transcervical ascending infections. Most bacterial and a few viral, e.g., herpes simplex 2 infections are acquired by the cervicovaginal route. Such infections may be acquired in utero or around the time of birth. In general, the fetus acquires the infection either by inhaling infected amniotic fluid into the lungs shortly before birth or by passing through an infected birth canal during delivery. As stated earlier, preterm birth is a common and unfortunate consequence of infection. Preterm birth due to infection may be related either to damage and rupture of the amniotic sac as a direct consequence of the inflammation, or to the induction of labor by prostaglandins released from infiltrating neutrophils. Inflammation of the placental membranes and cord are usually seen, but the presence or absence and severity of chorioamnionitis do not necessarily correlate with the severity of the fetal infection. In the fetus infected by inhalation of amniotic fluid, pneumonia, sepsis, and meningitis are the most common sequelae. Transplacental hematologic infections. Most parasitic, e.g., toxoplasma, malaria, and viral infections and a few bacterial infections, i.e., listeria, treponema, gain access to the fetal bloodstream transplacentally via the Figure 10.8 necrotizing enterocolitis (NEC). A postmortem examination in a severe case of NEC shows the entire small bowel is markedly distended with a perilously thin wall. Usually this implies impending perforation. B. The congested portion of the ileum corresponds to areas of hemorrhagic infarction and transmural necrosis microscopically. Submucosal gas bubbles, pneumatosis intestinalis, can be seen in several areas. Arrows. 462 Chapter 10 Diseases of Infancy and Childhood. Fetal hydrops. Figure 10.9 Bone marrow from an infant infected with parvovirus B19. The arrows indicate two erythroid precursors with large homogeneous intranuclear inclusions and a surrounding peripheral rim of residual chromatin. Chorionic villi. This hematogenous transmission may occur at any time during gestation or occasionally, as may be the case with hepatitis B and HIV, at the time of delivery via maternal to fetal transfusion. The clinical manifestations of these infections are highly variable, depending largely on the gestational timing and microorganism involved. Parvovirus B19, which causes erythema infectiosum or fifth disease of childhood, in immunocompetent older children, can infect 1% to 5% of seronegative non-immune pregnant women, and the vast majority have a normal pregnancy outcome. Adverse pregnancy outcomes in a minority of intrauterine infections include spontaneous abortion, particularly in the second trimester, stillbirth, hydrops fetalis, see later, and congenital anemia. Parvovirus B19 has a particular tropism for erythroid cells, and diagnostic viral inclusions can be seen in early erythroid progenitors in infected infants. Fig. 10.9. The torch group of infections, see earlier, are grouped together because they may evoke similar clinical and pathologic manifestations, including fever, encephalitis, chorioretinitis, hepatosplenomegaly, pneumonitis, myocarditis, hemolytic anemia, and vesicular or hemorrhagic skin lesions. Such infections occurring early in gestation may also cause chronic sequelae in the child, including growth retardation and intellectual disability, cataracts, congenital cardiac anomalies, and bone defects. Sepsis. Perinatal sepsis can be grouped clinically based on early onset within the first 7 days of life versus late onset from 7 days to 3 months. Most cases of early onset sepsis are acquired at or shortly before birth and tend to result in clinical signs and symptoms of pneumonia, sepsis, and occasionally meningitis within 4 or 5 days of life. Group B streptococcus is the most common cause of early onset sepsis as well as early onset bacterial meningitis. Infections with Listeria and Candida have longer latent periods between the time of microorganism inoculation and the appearance of clinical symptoms and present as late onset sepsis. Fetal hydrops refers to the accumulation of edema fluid in the fetus during intrauterine growth. In the past, hemolytic anemia caused by Rh blood group incompatibility between mother and fetus, immune hydrops, was the most common cause, but with the successful prophylaxis of this disorder during pregnancy, non-immune hydrops is more common. The intrauterine fluid accumulation can be quite variable, from progressive, generalized edema of the fetus, hydrops fetalis, a usually lethal condition, to more localized edema, such as isolated pleural and peritoneal effusions, or postnuptial fluid accumulation, cystic hygroma, see later, that are compatible with life. Immune hydrops. Immune hydrops is a hemolytic disease caused by blood group antigen incompatibility between mother and fetus. When the fetus inherits red cell antigenic determinants from the father that are foreign to the mother, a maternal immune reaction may occur. The major antigens known to induce clinically significant immunologic reactions are certain Rh antigens and the ABO blood groups. The reaction occurs in second and subsequent pregnancies in an Rh-negative mother with an Rh-positive father. Etiology and pathogenesis. The underlying basis of immune hydrops is the immunization of the mother by blood group antigens on fetal red cells and the free passage of antibodies from the mother through the placenta to the fetus. Fig. 10.10. Fetal red cells may reach the maternal circulation during the last trimester of pregnancy, when the cytotrophoblast is no longer present as a barrier, or during childbirth itself. The mother thus becomes sensitized to the foreign antigen. The initial exposure to Rh antigen evokes the formation of IgM antibodies that, unlike Ig antibodies, do not cross the placenta. Thus, Rh disease is uncommon with the first pregnancy. Exposure during a subsequent pregnancy generally leads to a brisk Ig antibody response and the risk of immune hydrops. Of the numerous antigens included in the Rh system, only the D antigen is a major cause of Rh incompatibility. Several factors influence the immune response to Rhd-positive fetal red cells that reach the maternal circulation. Concurrent ABO incompatibility protects the mother against Rh immunization because the fetal red cells are promptly coated and removed from the maternal circulation by anti-A or anti-B IgM antibodies that do not cross the placenta. The antibody response depends on the dose of immunizing antigen. Hence, hemolytic disease develops only when the mother has experienced a significant transplacental bleed, greater than 1 milliliter of Rh-positive fetal red cells. The incidence of maternal Rh isoimmunization has decreased significantly since the use of rhesus immune globulin (RhIg) containing anti-D antibodies. Administration of RhIg at 28 weeks of gestation and within 72 hours of delivery to Rh-negative mothers significantly decreases the risk for hemolytic disease in Rh-positive neonates. Fetal hydrops 463. Rh mother, previously sensitized to Rh antigen by transfusion or Rh plus fetus. IgM, stimulate antibody production against Rh antigen Ig. Placenta, Rh plus antigen, antibody attachment to extramedullary. In subsequent pregnancies, RhIg is also administered following abortions, because these two can lead to immunization. Antenatal identification and management of the at-risk fetus have been greatly facilitated by amniocentesis and chorionic villus and fetal blood sampling. In addition, cloning of the Rhd gene has resulted in efforts to determine fetal Rh status using maternal serum because it contains fetal DNA. When identified, cases of severe intrauterine hemolysis may be treated by fetal intravascular transfusions via the umbilical cord and early delivery. The pathogenesis of fetal hemolysis caused by maternal fetal ABO incompatibility is slightly different from that caused by differences in the Rh antigens. ABO incompatibility occurs in approximately 20% to 25% of pregnancies, but laboratory evidence of hemolytic disease occurs in only 1 in 10 of such infants, and the hemolytic disease is severe enough to require treatment in only 1 in 200 cases. Several factors account for this. First, most anti-A and anti-B antibodies are of the IgM type and hence do not cross the placenta. Second, neonatal red cells express blood group antigens A and B poorly. Third, many cells other than red cells express A and B antigens and thus absorb some of the transferred antibody. ABO hemolytic disease occurs almost exclusively in infants of group A or B who were born of group O mothers. For unknown reasons, certain group O women possess Ig antibodies directed against group A or B antigens, or both even without prior sensitization. Therefore, the firstborn may be affected. Fortunately, even with transplacentally acquired antibodies, lysis of the infant's red cells is minimal. There is no effective protection against ABO reactions. There are two consequences of excessive destruction of red cells in the neonate. See Fig. 10.10. The severity of these changes varies considerably, depending on the degree of hemolysis and the maturity of the infant. Anemia is a direct result of red cell loss. If hemolysis is mild, increased red cell production may suffice to maintain near normal levels of red cells. However, with more severe hemolysis, progressive anemia develops and may result in hypoxic injury to the heart and liver. Because of liver injury, plasma protein synthesis decreases, and levels of these proteins may drop to as low as 2 to 2.5 mg per deciliter. Cardiac hypoxia may lead to cardiac decompensation and failure. The combination of reduced plasma oncotic pressure and increased hydrostatic pressure in the circulation, secondary to cardiac failure, results in generalized edema and anasarca, culminating in hydrops fetalis. Jaundice develops because hemolysis produces unconjugated bilirubin, Chapter 18. Bilirubin also passes through the infant's poorly developed blood-brain barrier. Being water insoluble, bilirubin binds to lipids in the brain and can damage the CNS, causing kernicterus. See Fig. 10.13. Non-immune hydrops. The three major causes of non-immune hydrops include cardiovascular defects, chromosomal anomalies, and fetal anemia. Both structural and functional cardiovascular defects, such as congenital malformations and arrhythmias, may result in intrauterine cardiac failure and hydrops. Among the chromosomal anomalies, 45, X karyotype Turner syndrome, and trisomies 21 and 18 are associated with fetal hydrops because of the accompanying structural cardiac anomalies. In Turner syndrome, abnormalities of lymphatic drainage from the neck may lead to postnuptial fluid accumulation, cystic hygromas as well. Fetal anemia, not caused by Rh or ABO-associated antibodies, can also result in hydrops. In fact, in some parts of the world, e.g., Southeast Asia, severe fetal anemia due to homozygous alpha thalassemia, resulting from deletion of all 4 alpha-globin genes, is probably the most common cause of non-immune hydrops. Chapter 14. Transplacental infection by parvovirus B19 is rapidly emerging as an important cause of hydrops, see earlier. The virus gains preferential entry into erythroid precursors, normoblasts, where it replicates, leading to apoptosis of red cell progenitors and isolated red cell aplasia. Parvoviral intranuclear inclusions can be seen within circulating and marrow erythroid precursors, see Fig. 10.9. Approximately 10% of cases of non-immune hydrops are related to monozygous twin pregnancies and twin-to-twin transfusion occurring through anastomoses between the two circulations. In up to 20% of cases, the cause remains unknown. Morphology. The anatomic findings in fetuses with intrauterine fluid accumulation vary with both the severity of the disease and the underlying etiology. As previously noted, hydrops fetalis represents the most severe and generalized manifestation, Fig. 10.11 and lesser degrees. Chapter 10 Diseases of Infancy and Childhood. A.B. Figure 10.11 Hydrops fetalis. A. There is generalized accumulation of fluid in the fetus. B. Fluid accumulation is particularly prominent in the soft tissues of the neck, and this condition has been termed cystic hygroma. Cystic hygromas are characteristically seen, but not limited to, constitutional chromosomal anomalies such as 45, X karyotypes. Courtesy Dr. Beverly Rogers, Department of Pathology, University of Texas Southwestern Medical Center, Dallas, Texas. Of edema such as isolated pleural, peritoneal, or postnuptial fluid collections can occur. Accordingly, infants may be stillborn, die within the first few days, or recover completely. The presence of dysmorphic features suggests a chromosomal abnormality. Postmortem examination may reveal an underlying cardiac anomaly. In hydrops associated with fetal anemia, both the fetus and placenta are characteristically pale. In most cases the liver and spleen are enlarged from cardiac failure and congestion. Additionally, the bone marrow demonstrates compensatory hyperplasia of erythroid precursors, parvovirus-associated red cell aplasia being a notable exception, and extramedullary hematopoiesis is present in the liver, spleen, lymph nodes, and possibly other tissues such as the kidneys, lungs, and even the heart. Fig. 10.12. The increased. Figure 10.12 Numerous islands of extramedullary hematopoiesis, small blue cells, are scattered among mature hepatocytes in the liver of this infant with non-immune hydrops fetalis. Hematopoietic activity accounts for the presence in the peripheral circulation of large numbers of immature red cells, including reticulocytes and erythroblasts, erythroblastosis fetalis. The most serious threat in fetal hydrops is CNS damage, known as kernicterus. Fig. 10.13. The affected brain is enlarged and edematous and, when sectioned, has a bright yellow color, particularly the basal ganglia, thalamus, cerebellum, cerebral gray matter, and spinal cord. The precise level of bilirubin that induces kernicterus is unpredictable, but neural damage usually requires a blood bilirubin level greater than 20 mg per deciliter in term infants. In premature infants this threshold may be considerably lower. 0.464. Clinical features. The clinical manifestations of fetal hydrops vary with the severity of the disease and can be inferred from the preceding discussion. Minimally affected infants display pallor, possibly accompanied by hepatosplenomegaly, to which may be added jaundice with more severe hemolytic reactions, whereas the most gravely ill neonates present with intense jaundice, generalized edema, and signs of neurologic injury. These infants may be supported by a variety of measures, including phototherapy. Visual light oxidizes toxic unconjugated bilirubin to harmless, readily excreted, water-soluble diperols and, in severe cases, total exchange transfusion of the infant. Inborn errors of metabolism and other genetic disorders. Inborn errors of metabolism are genetic disorders that give rise to defects in metabolism. Since Sir Archibald Garrett. Errors of metabolism and other genetic disorders. 465. Figure 10.13 Kernicterus. Note the yellow discoloration of the brain parenchyma due to bilirubin accumulation, which is most prominent in the basal ganglia deep to the ventricles. Coined the term in 1908, the number of recognized metabolic diseases has increased exponentially. Most inborn errors of metabolism are rare diseases that are generally inherited as autosomal recessive or X-linked traits. Chapter 5. Mitochondrial disorders. Chapter 5 form a distinct entity by themselves. Some of the clinical features that suggest an underlying metabolic disorder in a neonate are listed in Table 10.2. The clinical manifestations of these diseases are generally the result of either abnormal metabolite accumulation or deficiency of the desired product. 3 genetic disorders, phenylketonuria, PKU, galactosemia, and cystic fibrosis, are selected for discussion here. PKU and galactosemia are reviewed because their early diagnosis via neonatal screening programs is particularly important, and early death or intellectual disability can be prevented with appropriate dietary regimens. Cystic fibrosis is included because it is one of the most common, potentially lethal diseases occurring in individuals of Caucasian descent. Phenylketonuria. There are several variants of this inborn error of metabolism, which affects 1 in 10,000 live-born Caucasian infants. The most common form, referred to as classic PKU, is quite common in persons of Scandinavian descent and is distinctly uncommon in African American and Jewish populations. PKU is an autosomal recessive disorder caused by a severe deficiency of the enzyme phenylalanine hydroxylase PA, leading to hyperphenylalaninamia. Affected infants are normal at birth but within a few weeks develop an elevated plasma phenylalanine level, which impairs brain development. Usually by 6 months of life, severe intellectual disability becomes evident. Fewer than 4% of untreated phenylketonuria children have IQs greater than 50 or 60. About 1/3 of these children are never able to walk, and 2/3 cannot talk. Seizures, other neurologic abnormalities, decreased pigmentation of hair and skin, a characteristic musty odor, and eczema often accompany the intellectual disability in untreated children. Hyperphenylalaninamia and the resultant intellectual disability can be avoided by restricting phenylalanine intake early in life. Hence, all states in the United States have adopted screening procedures to detect PKU in the immediate postnatal period. Many female PKU patients, if treated with dietary restriction early in life, reach childbearing age and are clinically asymptomatic. Most of them have marked hyperphenylalaninamia, because dietary treatment is discontinued after they reach adulthood. Between 75% and 90% of children born to such women have intellectual disability and are microcephalic, and 15% have congenital heart disease, even though the infants themselves are heterozygotes. This syndrome, termed maternal PKU, results from the teratogenic effects of phenylalanine or its metabolites that cross the placenta and affect specific fetal organs during development. The presence and severity of the fetal anomalies directly correlate with the maternal phenylalanine level, so it is imperative that maternal dietary restriction of phenylalanine be initiated before conception and continued throughout pregnancy. The biochemical abnormality in PKU is an inability to convert phenylalanine into tyrosine. In normal children, less than 50% of the dietary intake of phenylalanine is necessary for protein synthesis. The remainder is converted to tyrosine by the phenylalanine hydroxylase system Fig. 10.14. When phenylalanine metabolism is blocked because of a lack of functional PA, minor shunt pathways come into play, yielding several off-pathway metabolites that are 10.2 inborn abnormalities. 466 Chapter 10 Diseases of Infancy and Childhood. Phenylalanine plus O2 phenylalanine hydroxylase. PA, tyrosine plus H2O. Figure 10.14 The phenylalanine excreted in large amounts in the urine and sweat. These impart a strong musty or mousy odor to affected infants. It is believed that excess phenylalanine or its metabolites contribute to the brain damage in PKU. Concomitant lack of tyrosine, see Fig. 10.14, a precursor of melanin, is responsible for the light color of hair and skin. At the molecular level, over 500 mutant alleles of the PA gene have been identified. Mutations in both PA alleles are required to develop the disease. Infants with mutations resulting in severely reduced PA activity present with markedly elevated blood phenylalanine levels and the classic features of PKU, and those with up to 6% residual PA activity present with milder disease. Some PA mutations result in only modest elevations of blood phenylalanine levels without associated neurologic damage. This latter condition, referred to as benign hyperphenylalaninamia, is important to recognize because these individuals may have positive screening tests but do not develop the stigmata of classic PKU. Because of the numerous disease-causing alleles of the PA gene, molecular diagnosis is not feasible, and measurement of serum phenylalanine levels is necessary to differentiate benign hyperphenylalaninamia from PKU. The levels in the latter are typically 5-fold or more above normal. Once a biochemical diagnosis is established, the specific mutation causing PKU can be determined. With the identification of the mutation, carrier testing of at-risk family members can be performed. Although 98% of PKU is attributable to mutations in PA, approximately 2% occur due to abnormalities in synthesis or recycling of the cofactor tetrahydrobiopterin BH4, see Fig. 10.14. It is clinically important to recognize these variant forms of PKU because they cannot be treated by dietary restriction of phenylalanine. Galactosemia. Galactosemia is an autosomal recessive disorder of galactose metabolism resulting from accumulation of galactose 1-phosphate in tissues. It affects 1 in 60,000 live-born infants. Normally, lactose, the major carbohydrate of mammalian milk, is split into glucose and galactose in the intestinal microvilli by lactase. Galactose is then converted to glucose in several steps catalyzed by distinct enzymes. 2 variants of galactosemia have been identified. In the more common variant, there is a total lack of galactose 1-phosphate or ribyltransferase GALT. The rare variant arises from a deficiency of galactokinase. Because galactokinase deficiency leads to a milder form of the disease that is not associated with intellectual disability, it is not considered in this discussion. Tetrahydrobiopterin BH4, dihydrobiopterin NAD. As a result of GALT deficiency, galactose 1-phosphate accumulates in many locations, including the liver, spleen, lens of the eye, kidneys, heart muscle, cerebral cortex, and erythrocytes. Alternative metabolic pathways are activated, leading to the production of galactitol, a polyol metabolite of galactose, and galactonate, an oxidized byproduct of excess galactose, both of which also accumulate in the tissues. Long-term toxicity in galactosemia has been variously imputed to these metabolic intermediates. Heterozygotes may have a mild enzyme deficiency and are spared the clinical and pathologic consequences of the homozygous state. The clinical picture is variable, probably reflecting the heterogeneity of mutations in the GALT gene. The liver, eyes, and brain bear the brunt of the damage. The early to develop hepatomegaly is due largely to fatty change, but in time widespread scarring that closely resembles the cirrhosis of alcohol abuse may supervene. Opacification of the lens cataract develops, probably because the lens absorbs water and swells as galactitol, produced by alternative metabolic pathways, accumulates and increases osmotic pressure. Nonspecific alterations appear in the CNS, including loss of nerve cells, gliosis, and edema, particularly in the dentate nuclei of the cerebellum and the olivary nuclei of the medulla. Similar changes may occur in the cerebral cortex and white matter. These infants fail to thrive almost from birth. Vomiting and diarrhea appear within a few days of milk ingestion. Jaundice and hepatomegaly usually become evident during the first week of life and may seem to be a continuation of the physiologic jaundice of the newborn. Cataracts develop within a few weeks, and within the first 6 to 12 months of life intellectual disability may be detected. Even in untreated infants, however, the disability is usually not as severe as that seen in PKU. Accumulation of galactose and galactose 1-phosphate in the kidney impairs amino acid transport, resulting in aminoaciduria. There is an increased frequency of fulminant Escherichia coli septicemia, possibly arising from depressed neutrophil bactericidal activity. Hemolysis and coagulopathy in the newborn period can occur as well. Newborn screening tests are widely utilized in the United States. They depend on fluorometric assay of GALT enzyme activity on a dried blood spot. A positive screening test must be confirmed by assay of GALT levels in red cells. Antenatal diagnosis is possible by assay of GALT activity in cultured amniotic fluid cells or determination of galactitol level in amniotic fluid supernatant. Many of the clinical and morphologic changes of galactosemia can be prevented or ameliorated by early removal of galactose from the diet for at least the first 2 years of life. Control instituted soon after birth prevents the cataracts and liver damage and permits almost normal development. Even with dietary restrictions, however, it is now established that older patients are frequently affected by a speech disorder and gonadal failure, especially premature ovarian failure and, less commonly, ataxia. Cystic fibrosis, mucoviscidosis. Cystic fibrosis is an inherited disorder of ion transport that affects fluid secretion in exocrine glands and in the epithelial lining of the respiratory, gastrointestinal, and inborn errors of metabolism and other genetic disorders. 467. Reproductive tracts. In many individuals this disorder leads to abnormally viscous secretions that obstruct organ passages, resulting in most of the clinical features of this disorder, such as chronic lung disease secondary to recurrent infections, pancreatic insufficiency, steatorrhea, malnutrition, hepatic cirrhosis, intestinal obstruction, and male infertility. These manifestations may appear at any point in life from before birth to much later in childhood or even in adolescence. Cystic fibrosis is the most common lethal genetic disease that affects Caucasian populations, with an incidence of approximately 1 in 2,500 live births. The carrier frequency in the United States is 1 in 20 among Caucasians but significantly lower in African Americans, Asians, and Hispanics. Although cystic fibrosis follows an autosomal recessive transmission pattern, recent data suggest that even heterozygote carriers have a higher incidence of respiratory and pancreatic disease compared with the general population. In addition, despite the classification of cystic fibrosis as a Mendelian disorder, there is a wide degree of phenotypic variation that results from 3 additional factors: diverse mutations in the gene associated with cystic fibrosis, the tissue-specific effects of the encoded gene product, and the influence of modifier genes. Cystic fibrosis gene. Normal structure and function. The primary defect in cystic fibrosis is abnormal transport of chloride and bicarbonate ions mediated by an anion channel encoded by the cystic fibrosis transmembrane conductance regulator (CFTR) gene on chromosome 7q31.2. The 1480 amino acid polypeptide encoded by CFTR has 2 transmembrane domains, each containing 6 alpha helices, 2 cytoplasmic nucleotide binding domains (NBDs), and a regulatory domain (R domain) that contains protein kinase A and C phosphorylation sites (Fig. 10.15). The 2 transmembrane domains form a channel through which chloride passes. Activation of the CFTR channel is mediated by agonist-induced increases in cyclic adenosine monophosphate (CAMP), which lead to activation of a protein kinase that phosphorylates the R domain. Adenosine triphosphate (ATP) binding and hydrolysis occurs at the NBD and is essential for opening and closing of the channel pore, which is enhanced by the presence of phosphorylated R domain. Several important facets of CFTR function have emerged in recent years. CFTR regulates multiple ion channels and cellular processes. Although initially characterized as a chloride conductance channel, it is now recognized that CFTR can regulate additional ion channels and cellular processes. These include so-called outwardly rectifying chloride channels, inwardly rectifying potassium channels, here 6.1, the epithelial sodium channel, ENAC, gap junction channels, and cellular processes involved in ATP transport and mucus secretion. Of these, the interaction of CFTR with the ENaC has possibly the most pathophysiologic relevance in cystic fibrosis. The ENaC is situated on the apical surface of epithelial cells and is responsible for sodium uptake from the luminal fluid, rendering the luminal fluid hypotonic. ENaC is inhibited by normally functioning CFTR, hence, in cystic fibrosis, ENaC activity increases, markedly augmenting sodium uptake across the apical membrane. The importance of this phenomenon is nucleus processing, CFTR, figure 10.15 top. Discussed later in the context of pulmonary and gastrointestinal pathology in cystic fibrosis. The one exception to this is the human sweat ducts, where ENaC activity decreases as a result of CFTR mutations. Therefore, hypertonic fluid with high sodium chloride, the sine qua non of classic cystic fibrosis, is formed. This is the basis for the salty sweat that mothers can often detect in their affected infants. The functions of CFTR are tissue-specific, therefore, the impact of a mutation in CFTR is also tissue-specific. The major function of CFTR in the sweat gland ducts is to reabsorb luminal chloride ions and augment sodium reabsorption via the ENaC, see earlier. Therefore, in the sweat ducts, loss of CFTR function leads to decreased reabsorption of sodium chloride and the production of hypertonic sweat Fig. 10.16. However, in the respiratory and intestinal epithelium, CFTR is one of the most important avenues for active luminal secretion of chloride. At these sites, CFTR mutations result in loss or reduction of chloride secretion into the lumen Fig. 10.16 and active luminal sodium absorption is increased due to loss of inhibition of ENaC activity. These changes in ion distribution result in increased passive water reabsorption from the lumen, lowering the water content of the surface fluid. Golgi. N. Agonist. Camp. Translation. Folding. Folding. ATP. ATP. 468 Chapter 10 Diseases of Infancy and Childhood. Normal cystic fibrosis. Lumen of sweat duct. Lumen of sweat duct. CFTR. CFTR. ENaC. CL. Normal cystic fibrosis. Figure 10.16 CFTR chloride channel defect in the sweat duct's top causes increased sodium chloride concentration in sweat. In the airway bottom, patients with cystic fibrosis have decreased chloride secretion and increased sodium and water reabsorption, leading to dehydration of the mucus layer coating epithelial cells, defective mucociliary action, and mucus plugging of airways. CFTR, cystic fibrosis transmembrane conductance regulator, ENaC, epithelial sodium channel. Layer coating mucosal cells. Thus, unlike in the sweat ducts, there is no difference in the salt concentration of the surface fluid layer coating respiratory and intestinal mucosal cells in those with cystic fibrosis when compared with normal individuals. Instead, the pathogenesis of respiratory and intestinal complications in cystic fibrosis seems to stem from an isotonic but low-volume surface fluid layer. In the lungs, this dehydration leads to defective mucociliary action and the accumulation of hyperconcentrated, viscid secretions that obstruct the air passages and predispose to recurrent pulmonary infections. CFTR regulates transport of bicarbonate ions. CFTR plays both a direct and indirect role in regulating bicarbonate transport across the apical epithelial membrane. The anion channel of CFTR is not entirely specific for chloride and has been found to be permeable to bicarbonate as well. In addition, CFTR has reciprocal interactions with the SLC26 family of anion exchangers, which are co-expressed on the apical surface with CFTR. In some CFTR mutants, chloride transport is completely or substantially preserved, and bicarbonate transport is markedly abnormal. Normal tissue secretes alkaline fluids. In contrast, fluids that are acidic due to absence of bicarbonate ions are secreted by epithelia harboring these mutant CFTR alleles. The acidity of secretions results in decreased luminal pH that can lead to a variety of adverse effects such as increased mucin precipitation and plugging of ducts and increased binding of bacteria to plugged mucins. Pancreatic insufficiency, a feature of classic cystic fibrosis, is virtually always present when there are CFTR mutations with abnormal bicarbonate conductance. Cystic fibrosis gene, mutational spectrum and genotype-phenotype correlation. Since the CFTR gene was cloned in 1989, more than 2,000 disease-associated mutations have been identified. Only 5 mutations have a relative frequency of 1% or more of disease-causing genotypes. Most of the mutations are missense alterations, but frameshift, splicing, and nonsense mutations are also present. The mutations can be grouped into 6 classes based on their effect on the CFTR protein Fig. 10.17. Class 1 to 3 mutations result in less than 10% residual CFTR activity and are termed severe mutations, errors of metabolism and other genetic disorders. 469. Cystic defect. A. In Class Pro. Class 1. Chapter 10. And Class 4 to V mutations result in less than 20% residual CFTR activity and are termed mild mutations. Class 1. Defective protein synthesis null mutations. These mutations result in premature termination of protein translation and are associated with complete lack of CFTR protein at the apical surface of epithelial cells. Class 2. Abnormal protein folding, processing, and trafficking processing mutations. These mutations result in defective processing of the protein from the endoplasmic reticulum to the Golgi apparatus. The protein does not become fully folded and glycosylated and is instead degraded before it reaches the cell surface. The most common CFTR mutation is a class 2 caused by deletion of 3 nucleotides coding for phenylalanine at amino acid position 508, delta F 508. Worldwide, this mutation can be found in approximately 70% of Caucasian cystic fibrosis patients. Class 2 mutations are associated with near-complete lack of CFTR protein at the apical surface of epithelial cells. Class 3. Defective regulation gating mutations. Mutations in this class prevent activation of CFTR by abrogating ATP binding and hydrolysis, an essential prerequisite for ion transport, see earlier. Thus, there is a normal amount of CFTR on the apical surface, but it is non-functional. Class 4. Decreased conductance conduction mutations. These mutations typically occur in the transmembrane domain of CFTR, which forms the ionic pore for chloride transport. There is a normal amount of CFTR at the apical membrane, but with reduced chloride conduction. Class 5. Reduced abundance production mutations. These mutations typically affect intronic splice sites or the CFTR promoter, such that there is a reduced amount of normal protein. Class 6. Decreased membrane CFTR stability instability mutations. These mutations give rise to fully processed and functional proteins but with greatly reduced membrane stability. Because cystic fibrosis is an autosomal recessive disease, affected individuals harbor mutations on both alleles. However, the nature of mutations on each of the 2 alleles can have a remarkable effect on the overall phenotype, as well as on organ-specific manifestations. Fig. 10.18. Thus, 2. Severe mutations that produce virtual absence of membrane CFTR function are associated with the classic cystic fibrosis phenotype, pancreatic insufficiency, cinepulmonary infections, and gastrointestinal symptoms, and the presence of a mild mutation on one or both alleles results in a less severe phenotype. This general dictum of genotype-phenotype correlation is most consistent for pancreatic disease, wherein the presence of one allele with a mild mutation associated with some CFTR activity can prevent the pancreatic insufficiency that is virtually always seen with homozygosity for severe mutations. In contrast, genotype-phenotype correlations are far less consistent in pulmonary disease, due to the effect of secondary modifiers, see later. As genetic testing for CFTR mutations has expanded, it has become evident that some patients who present with clinical features apparently unrelated to cystic fibrosis may also harbor CFTR mutations. These include individuals with idiopathic chronic pancreatitis, late-onset chronic pulmonary disease, idiopathic bronchiectasis, and obstructive azoospermia caused by bilateral absence of the vas deferens. See detailed discussion of individual phenotypes later. Most of these patients do not demonstrate other features of cystic fibrosis. Despite the presence of biallelic CFTR mutations, these patients are classified as having non-classic or atypical cystic fibrosis. Identifying these individuals is important not only for subsequent management, but also for genetic counseling. Genetic and environmental modifiers. Although cystic fibrosis remains one of the best known examples of the one gene, one disease axiom, there is considerable evidence that genes other than CFTR modify the frequency and severity of certain organ-specific manifestations, especially pulmonary manifestations and neonatal meconium ileus. Not surprisingly, polymorphisms in genes whose products modulate neutrophil function in response to bacterial infections act as modifier loci for the severity of pulmonary disease in cystic fibrosis. Examples of such modifier genes include mannose-binding lectin-2, MBL2, transforming growth factor beta-1, TGF-beta-1, and interferon-related developmental regulator 1, IFRD1. It is postulated that polymorphisms in these genes regulate the level of CFTR function less than 5%, less than 10%, less than 20%, 50%. Sinuses: severe chronic sinusitis, moderate chronic sinusitis, increased rate of chronic sinusitis. Lungs: severe lung disease, variable lung disease, increased rate of lung disease. Sweat glands: high sweat. Errors of metabolism. Resistance of the lungs to exogenous infections with virulent microbes, see later, thus modifying the natural history of cystic fibrosis. Environmental modifiers may also explain some of the significant phenotypic differences between individuals who share the same CFTR genotype. This is best exemplified in pulmonary disease, where CFTR genotype-phenotype correlations can be perplexing. As stated earlier, defective mucociliary action because of deficient hydration of the mucus results in an inability to clear bacteria from the airways. Pseudomonas aeruginosa species, in particular, colonize the lower respiratory tract, first intermittently and then chronically. Concurrent viral infections predispose to such colonization. The static mucus creates a hypoxic microenvironment in the airway surface fluid, which in turn favors the production of alginate, a mucoid polysaccharide capsule, by the colonizing bacteria. Alginate production permits the formation of a biofilm that protects the bacteria from antibodies and antibiotics, allowing them to evade host defenses and produce a chronic destructive lung disease. Antibody and cell-mediated immune reactions induced by the organisms result in further pulmonary destruction, but are ineffective against the organism. Approximately 80% of cystic fibrosis patients are colonized by Pseudomonas aeruginosa by 20 years of age. Chronic colonization by these bacteria is a significant contributor to the morbidity and mortality of cystic fibrosis. It is evident, therefore, that in addition to genetic factors e.g., class of mutation, a plethora of environmental modifiers e.g., intercurrent and concurrent infections by microorganisms can influence the severity and progression of lung disease in cystic fibrosis. Morphology. The anatomic changes are highly variable in distribution and severity. In individuals with non-classic cystic fibrosis, the disease is quite mild and does not seriously disturb their growth and development. In others, the pancreatic involvement is severe and impairs intestinal absorption because of pancreatic insufficiency, Chapter 19, so malabsorption stunts development and postnatal growth. In others, the mucus secretion defect leads to defective mucociliary action, obstruction of bronchi and bronchioles, and crippling fatal pulmonary infections. In all variants, the sweat glands are morphologically unaffected. Pancreatic abnormalities are present in approximately 85% to 90% of patients with cystic fibrosis. In milder cases, there may be only accumulation of mucus in the small ducts with some dilation of the exocrine glands. In more severe cases, usually seen in older children or adolescents, the ducts are completely plugged, causing atrophy of the exocrine glands and progressive fibrosis Fig. 10.19. Atrophy of the exocrine portion of the pancreas may occur, leaving only islets within a fibrofatty stroma. The loss of pancreatic exocrine secretion impairs fat absorption, and the associated avitaminosis A may contribute to squamous metaplasia of the pancreatic duct lining epithelium, which is already injured by the inspissated mucus secretions. Thick viscid plugs of mucus may also be found in the small intestine of infants. Sometimes these cause small bowel obstruction, known as meconium ileus. Liver involvement follows the same basic pattern. Bile canaliculi are plugged by mucus material, accompanied by ductular. Figure 10.19 End-stage pancreatic disease in cystic fibrosis. The ducts are markedly dilated, and exocrine glands are destroyed and replaced by fibrous tissue, proliferation and portal inflammation. Hepatic steatosis is not an uncommon finding in liver biopsies. Over time, focal biliary cirrhosis develops in approximately one-third of patients, Chapter 18, which can eventually involve the entire liver, resulting in diffuse hepatic nodularity. Such severe hepatic involvement is encountered in less than 10% of patients. The salivary glands frequently show histologic changes similar to those described in the pancreas. Progressive dilation of ducts, squamous metaplasia of the lining epithelium, and glandular atrophy followed by fibrosis. The pulmonary changes are the most serious complications of this disease Fig. 10.20. These stem from the viscous mucus secretions of the submucosal glands of the respiratory tree, leading to secondary obstruction and infection of the air passages. The bronchioles are often distended with thick mucus associated with marked hyperplasia and hypertrophy of the mucus-secreting cells. Superimposed infections give rise to severe chronic bronchitis and bronchiectasis, Chapter 15. In many instances, lung abscesses develop. Staphylococcus aureus, Haemophilus influenzae, and Pseudomonas aeruginosa are the three most common organisms responsible for lung infections. As mentioned earlier, a mucoid form of P. aeruginosa, alginate-producing, is particularly frequent and causes chronic inflammation. Even more sinister is the increasing frequency of infection with another group of pseudomonads, the Burkholderia capacia complex, which includes at least 9 different species. Of these, infections with B. senescepacia are the most common in cystic fibrosis patients. This opportunistic bacterium is particularly hardy, and infection with this organism has been associated with fulminant illness, capacious syndrome, longer hospital stays, and increased mortality. Other opportunistic bacterial pathogens include Stenotrophomonas multifilia and nontuberculous mycobacteria. Allergic bronchopulmonary aspergillosis also occurs with increased frequency in cystic fibrosis. Azoospermia and infertility are found in 95% of males who survive to adulthood. Congenital bilateral absence of the vas deferens is a frequent finding in these patients. In some males, bilateral absence of the vas deferens may be the only feature suggesting an underlying CFTR mutation. Inborn. 472 Chapter 10 Diseases of Infancy and Childhood. Other gastrointestinal complications, and, in general, these individuals demonstrate excellent growth and development. A subset of patients with pancreas-sufficient cystic fibrosis have recurrent bouts of pancreatitis associated with acute abdominal pain and occasionally, life-threatening complications. These patients have other features of classic cystic fibrosis, such as pulmonary disease. Idiopathic, chronic pancreatitis can also occur as an isolated late-onset finding in the absence of other stigmata of cystic fibrosis, Chapter 19, biallelic CFTR mutations, usually 1, mild, 1, severe, are demonstrable in the majority of these. Endocrine pancreatic insufficiency, i.e., diabetes mellitus, occurs in up to 50% of adults with cystic fibrosis and is thought to be caused by cardiorespiratory complications, such clinical features. Few childhood diseases are as protean as cystic fibrosis in clinical manifestations. Table 10.3, Fig. 10.18. The symptoms are extremely varied and may appear at birth to years later, and involve one organ system or many. Approximately 5% to 10% of cases come to clinical attention at birth or soon after because of meconium ileus. Distal intestinal obstruction can also occur in older individuals, manifesting as recurrent episodes of right lower quadrant pain, sometimes associated with a palpable mass of meconium, with or without associated intussusception, in the right iliac fossa. Exocrine pancreatic insufficiency occurs in the majority, 85% to 90%, of patients with cystic fibrosis and is associated with severe CFTR mutations on both alleles, e.g., delta F508, delta F508, whereas 10% to 15% of patients with 1 severe and 1 mild pancreatic insufficiency is associated with protein and manifestations of malabsorption. The faulty fat absorption may induce deficiency of the fat soluble. Persistent diarrhea may result in rectal prolapse in up to 10%. The pancreas sufficient phenotype is usually abnormalities of 4. Infant patients in the United States. By 18 years of age, 80% of patients with classic cystic fibrosis harbor P. aeruginosa, and 3.5% harbor B. capacia. With the indiscriminate use of antibiotic prophylaxis against Staphylococcus, there has been an unfortunate resurgence of resistant strains of Pseudomonas in many patients. Individuals who carry 1 severe and 1 mild CFTR mutation may develop late-onset mild pulmonary disease, another example of non-classic or atypical cystic fibrosis. Patients with mild pulmonary disease usually have little or no pancreatic disease. Adult-onset idiopathic bronchiectasis has been linked to CFTR mutations in a subset of cases. Recurrent sinonasal polyps can occur in 10% to 25% of individuals with cystic fibrosis. Hence, children who present with this finding should be tested for cystic fibrosis. Significant liver disease occurs late in the natural history of cystic fibrosis and is gaining in clinical importance as life expectancies increase. As life expectancies increase. In fact, after cardiopulmonary and transplantation-related complications, liver disease is the most common cause of death in cystic fibrosis. Most studies suggest that symptomatic or biochemical liver disease has its onset at or around puberty, with a prevalence of approximately 13% to 17%. However, asymptomatic hepatomegaly may be present in up to 1/3 of individuals. Obstruction of the common bile duct may occur due to stones or sludge. It presents with abdominal pain and the acute onset of jaundice. As previously noted, diffuse biliary cirrhosis develops in less than 10% of individuals with cystic fibrosis. Fibrosis. Approximately 95% of males with cystic fibrosis are infertile as a result of obstructive azoospermia. As mentioned earlier, this is most commonly due to congenital bilateral absence of the vas deferens, which is caused in 80% of cases by biallelic CFTR mutations. In most cases, the diagnosis of cystic fibrosis is based on persistently elevated sweat electrolyte concentrations. Often the mother makes the diagnosis by recognizing her infant's abnormally salty sweat. Characteristic clinical findings: cinepulmonary disease and gastrointestinal manifestations, an abnormal newborn screening test, or a family history. The most common newborn screening test is based on measuring the blood level of immunoreactive trypsinogen, which is produced by the pancreas, and elevated levels result from pancreatic injury. A minority of patients with cystic fibrosis, especially those with at least 1 mild CFTR mutation, may have a normal or near normal sweat test less than 60 m. Measurement of nasal transepithelial potential difference in vivo can be a useful adjunct under these circumstances. Individuals with cystic fibrosis demonstrate a significantly more negative baseline nasal potential difference than controls. In patients with a positive screening test, suggestive clinical findings, or family history, or more than one of these, genetic analysis is warranted. Sequencing the CFTR gene is the gold standard for diagnosis of cystic fibrosis. There have been major improvements in the management of acute and chronic complications for cystic fibrosis, including more potent antimicrobial therapies, pancreatic enzyme replacement, and bilateral lung transplantation. New treatment modalities for restoring mutant CFTR function are being tested in clinical trials. Based on the molecular defect, 3 classes of agents are being developed: sudden potentiators. These agents keep the gate of the CFTR channel open. Hence they are most useful in gating class 3 and conduction class 4 mutations. They are also helpful for patients with production mutations class 5 by improving the function of reduced amounts of CFTR. Correctors. These agents assist in proper folding of the CFTR protein, thereby increasing its trafficking to the cell surface. Hence they have the potential to help patients with processing class 2 mutations. These include patients with delta F508, the most common CFTR mutation. Amplifiers. These agents increase the amount of CFTR protein the cell makes and thus can be useful for patients with production class 5 mutations. A combination therapy consisting of a potentiator agent and a small molecule that is a CFTR corrector has been approved for the treatment of patients with 2 copies of delta F508, the most common CFTR mutation. For treatment of patients with class 1 nonsense mutations, molecules that allow ribosomal read-through of premature stop codons are in the pipeline. Such therapy is also being tested in muscular dystrophies in which stop codons prevent synthesis of dystrophin, Chapter 27. Overall, improvements in the management of cystic fibrosis have extended the median life expectancy to 50 years. Sudden infant death syndrome. According to the National Institute of Child Health and Human Development, SIDS is defined as the sudden death of an infant under 1 year of age which remains unexplained after a thorough case investigation, including performance of a complete autopsy, examination of the death scene, and review of the clinical history. It is important to emphasize that many cases of sudden death in infancy may have an unexpected anatomic or biochemical basis discernible at autopsy, Table 10.4, and these should not be labeled as SIDS, but rather as sudden unexpected infant death, SUID. The Centers for Disease Control and Prevention estimates that SIDS accounts for approximately 1/2 of SUID cases in the United States. An aspect of SIDS that is not stressed in the definition is that the infant usually dies while asleep, mostly in the prone or side position, hence the pseudonyms of crib death or cot death. Epidemiology is infant deaths due to nutritional problems and infections have come under control in high-income countries. SIDS has assumed greater importance, including in the United States. SIDS is the leading cause of death between 1 month and 1 year of age in this country and the 4th leading cause of death overall in infancy, after congenital anomalies, diseases of prematurity and low birth weight, and maternal complications. Mostly because of nationwide back to sleep, now, safe to sleep campaigns, there has been a significant drop in SIDS-related mortality, from an estimated 120 deaths per 100,000 live births in 1992 to 35 per 100,000 in 2017. This number translates to about 1360 deaths due to SIDS in the United States. Despite the decline in SIDS and SUID in all races and ethnicities, the rate of SUID among 474 Chapter 10 diseases of infants from 10 parental approximately 90% of all SIDS deaths occur during the young maternal age, younger than 20 years of age. Maternal smoking during pregnancy. This narrow window of peak susceptibility is a unique drug abuse in either parent. Factors. Brain. The circumstances surrounding SIDS have been non-Hispanic Black 70 per 100,000 live births and American developmental period in homeostatic control, and 3 and Indian, Alaskan Native 77 per 100,000 live births infants exogenous stressor. According to this model, several factors was more than double that of non-Hispanic white infants. Morphology in infants who have died of suspected SIDS, a variety of findings have been reported at postmortem examination. They are usually subtle and of uncertain significance and are not present in all cases. Multiple petechiae are the most common finding, approximately 80% of cases. These are usually present on the thymus, visceral and parietal pleura, and epicardium. Grossly, the lungs are usually congested, and vascular engorgement with or without pulmonary edema is demonstrable microscopically in the majority of cases. These changes possibly represent agonal events, because they are found with comparable frequencies in explained sudden deaths in infancy. Within the upper respiratory system, larynx and trachea, there may be some histologic evidence of recent infection correlating with the clinical symptoms, although the changes are not sufficiently severe to account for death and should not detract from the diagnosis of SIDS. The CNS demonstrates astrogliosis of the brainstem and cerebellum. Sophisticated morphometric studies have revealed quantitative brainstem abnormalities such as hypoplasia of the arcuate nucleus or a decrease in brainstem neuronal populations in several cases. These observations are not uniform, however. Nonspecific findings include frequent persistence of hepatic extramedullary hematopoiesis and periadrenal brown fat. It is tempting to speculate that these latter findings relate to chronic hypoxemia, retardation of normal development, and chronic stress. Thus, autopsy usually fails to provide a clear cause of death, and this may well be related to the etiologic heterogeneity of SIDS. The importance of a postmortem examination rests in identifying other causes of SUID, such as unsuspected infection, congenital anomaly, or genetic disorder, see Table 10.4, the presence of any of which would exclude a diagnosis of SIDS, and tumors and tumor-like lesions of infancy and childhood. 475. The body's arousal responds to noxious stimuli such as episodic hypercarbia, hypoxia, and thermal stress encountered during sleep. The serotonergic 5-HT system of the medulla is implicated in these arousal responses, as well as regulation of other critical homeostatic functions such as respiratory drive, blood pressure, and upper airway reflexes. Abnormalities in serotonin-dependent signaling in the brainstem may be the underlying basis for SIDS in some infants. Epidemiologic and genetic studies have identified additional vulnerability factors for SIDS in the triple risk model. Infants who were born before term or who are low birth weight are at increased risk, and risk increases with decreasing gestational age or birth weight. Male sex is associated with a slightly greater incidence of SIDS. SIDS in a prior sibling is associated with a 5-fold relative risk of recurrence, highlighting the importance of a genetic predisposition. Traumatic child abuse must be carefully excluded under these circumstances. Most SIDS babies have an immediate prior history of a mild respiratory tract infection, but no single causative organism has been isolated. These infections may predispose an already vulnerable infant to even greater impairment of cardiorespiratory control and delayed arousal. In this context, laryngeal chemoreceptors have emerged as a putative, missing link between upper respiratory tract infections, the prone position, and SIDS. When stimulated, these laryngeal chemoreceptors typically elicit an inhibitory cardiorespiratory reflex. Stimulation of the chemoreceptors is augmented by respiratory tract infections, which increase the volume of secretions, and by mitochondrial fat, many as 5% of SUIDs. And tumor-like lesions of infancy and childhood. Only 2% of all malignant tumors occur in infancy and childhood. Nonetheless, cancer, including leukemia, accounts for about 16% of deaths in the United States in children between 5 and 14 years of age, and only accidents cause significantly more deaths. Benign tumors are even more common than cancers. Most benign tumors are of little concern, but on occasion they cause serious complications by virtue of their location or size. It is sometimes difficult to separate, on morphologic grounds, true tumors or neoplasms from tumor-like lesions in the infant and child. In this context, two special categories of tumor-like lesions should be distinguished from true tumors. The term heterotopia, or choristoma, is applied to microscopically normal cells or tissues that are present in abnormal locations. Examples of heterotopias include a rest of pancreatic tissue found in the wall of the stomach or small intestine, or small mass of adrenal cells found in the kidney, lungs, or ovaries. These heterotopic rests are usually of little significance, but they can be confused clinically with neoplasms. Rarely, they are sites of origin of true neoplasms, producing paradoxes such as an adrenal carcinoma arising in the ovary. The term hamartoma refers to an excessive, focal overgrowth of cells and tissues native to the organ in which it occurs. Although the cellular elements are mature and identical to those found in the remainder of the organ, they do not reproduce the normal architecture of the surrounding tissue. The line of demarcation between a hamartoma and a benign neoplasm is often unclear because both lesions can be clonal. Hemangiomas, lymphangiomas, rhabdomyomas of the heart, adenoma of the liver, and developmental cysts within the kidneys, lungs, or pancreas are interpreted by some as hamartomas and by others as true neoplasms. Their unequivocally benign histology, however, does not preclude bothersome and rarely life-threatening clinical problems in some cases. Benign tumors and tumor-like lesions. Virtually any tumor may be encountered in children, but within this wide array hemangiomas, fibrous lesions, and teratomas deserve special mention. You will notice that the most common neoplasms of childhood are soft tissue tumors of mesenchymal derivation. This contrasts with adults, in whom the most common tumors, benign or malignant, have an epithelial origin. Benign tumors of various tissues are described in greater detail in appropriate chapters, here A. 476 Chapter 10 Diseases of Infancy and Childhood. Figure 10.21 Congenital hemangioma at birth A, and at 2 years of age B after spontaneous regression. Courtesy Dr. Eduardo Eunice, Children's Hospital of Pittsburgh, Pennsylvania. Few comments are made about their special features in childhood. Hemangiomas are the most common tumors of infancy. Chapter 11. Architecturally, they do not differ from those occurring in adults. Both cavernous and capillary hemangiomas may be encountered, although the latter are often more cellular than in adults, a feature that is deceptively worrisome. In children, most are located in the skin, particularly on the face and scalp, where they produce flat to elevated, irregular, red-blue masses. Some of the flat, larger lesions considered by some to represent vascular ecstasias are referred to as port wine stains. Hemangiomas may enlarge along with the growth of the child, but in many instances they spontaneously regress. Fig. 10.21. In addition to their cosmetic significance, they can represent one facet of the hereditary disorder von Hippel-Lindau disease. Chapter 28. A subset of CNS cavernous hemangiomas can occur in the familial setting. These families harbor mutations in one of three genes, CRIT1, CCM2, or PDCD10. Fibrous tumors occurring in infants and children include sparsely cellular proliferations of spindle-shaped cells, designated as fibromatosis, and richly cellular lesions indistinguishable from fibrosarcomas occurring in adults, designated as congenital infantile fibrosarcomas. Biologic behavior cannot be predicted based on histology alone. However, despite their histologic similarities with adult fibrosarcomas, the congenital infantile variants have an excellent prognosis. A characteristic chromosomal translocation, T12, 15p13, q25, has been described in congenital infantile fibrosarcomas, which results in generation of an ETV6-NTRK3 fusion transcript. The normal ETV6 gene product is a transcription factor, and the NTRK3 gene product, also known as TRKC, is a tyrosine kinase. Like other tyrosine kinase fusion proteins found in human neoplasms, ETV6-NTRK3 is constitutively active and stimulates signaling through the oncogenic ROS-MAPK and PI3K-AKT pathways. Chapter 7. Among soft tissue tumors, the ETV6-NTRK3 fusion transcript is most commonly found in congenital infantile fibrosarcomas, making it a useful diagnostic marker. Teratomas illustrate the relationship of histologic maturity to biologic behavior. Teratomas may occur as benign, well-differentiated cystic lesions, mature teratomas as lesions of indeterminate potential, immature teratomas, or as unequivocally malignant teratomas, usually admixed with another germ cell tumor component such as yolk sac tumor. Chapter 21. They exhibit two peaks in incidence, the first at approximately 2 years of age and the second in late adolescence or early adulthood. The first peak is congenital neoplasms. The later occurring lesions may also be of prenatal origin but are more slowly growing. Sacrococcygeal teratomas are the most common teratomas of childhood, accounting for 40% or more of cases. Fig. 10.22. They occur with a frequency of 1 in 20,000 to 40,000 live. Figure 10.22 Sacrococcygeal teratoma. Note the size of the lesion compared with that of the stillbirth. Tumors and tumor-like lesions of infancy and childhood. 477. Births, and they are 4 times more common in girls than in boys. Approximately 10% of sacrococcygeal teratomas are associated with congenital anomalies, primarily defects of the hindgut and cloacal region and other midline defects, e.g., meningocele, spina bifida, not believed to result from local effects of the tumor. Approximately 75% of these tumors are mature teratomas, and about 12% are unequivocally malignant and lethal. The remainder are immature teratomas. Their malignant potential correlates with the amount of immature tissue, usually immature neuroepithelial elements, that are present. Most benign teratomas are encountered in younger infants, less than 4 months, whereas children with malignant lesions tend to be somewhat older. Other sites for teratomas in childhood include the testis, Chapter 21, ovary, Chapter 22, and various midline locations, such as the mediastinum, retroperitoneum, and head and neck. Malignant tumors. Cancers of infancy and childhood differ biologically and histologically from their counterparts occurring later in life. The main differences, some of which have already been alluded to, include the following. Incidence and type of tumor. Relatively frequent demonstration of a close relationship between abnormal development, teratogenesis, and tumor induction, oncogenesis. Prevalence of underlying familial genetic aberrations. Tendency of fetal and neonatal malignancies to regress or differentiate spontaneously. Improved survival or cure of many childhood tumors, so that more attention is now being devoted to minimizing the adverse delayed effects of chemotherapy and radiation therapy in survivors, including the development of second malignancies. Incidence and types. The most frequent childhood cancers arise in the hematopoietic system, nervous tissue including the central and sympathetic nervous system, adrenal medulla, and retina, soft tissue, bone, and kidney. This is in sharp contrast to adults, in whom the skin, lung, breast, prostate, and colon are the most common sites of tumors. Neoplasms that exhibit sharp peaks in incidence in children younger than 15 years of age and their approximate age distribution are indicated in Table 10.5. Leukemia alone accounts for more deaths in children under 15 years of age than all of the other tumors combined. Histologically, many of the malignant non-hematopietic pediatric neoplasms are unique. In general, they tend to have a more primitive embryonal indifferentiated appearance, often characterized by sheets of cells with small round nuclei, and frequently show features of organogenesis specific to the site of tumor origin. Because of this latter characteristic, these tumors are frequently designated by the suffix blastoma, for example, nephroblastoma, Wilm's tumor, hepatoblastoma, and neuroblastoma. Because of their primitive histologic appearance, many childhood tumors have been collectively referred to as small round blue cell tumors. The differential diagnosis of such tumors includes neuroblastoma, Wilm's tumor, lymphoma, Chapter 13, rhabdomyosarcoma. 10 Sci-5, common malignant neoplasms of infantia BLT childhood, 0 to 4 years, leukemia, retinoblastoma, neuroblastoma, Wilm's tumor, hepatoblastoma, 5 to 9 years leukemia. 10 to 14 years, neuroblastoma, renal cell carcinoma, hepatocellular carcinoma. Especially Ewing sarcoma, Ewing teratoma. Chapter 26, Ewing sarcoma, primitive neuroectodermal tumor, Chapter 26, medulloblastoma, Chapter 28, and retinoblastoma, Chapter 29. If the anatomic site of origin is known, diagnosis is usually possible on histologic grounds alone. Occasionally, a combination of chromosome analysis, immunoperoxidase stains, or electron microscopy is required. Two of these tumors are discussed here, the neuroblastic tumors, specifically neuroblastoma, and Wilm's tumor. The remaining tumors are discussed in their respective organ-specific chapters. Neuroblastic tumors. The term neuroblastic tumor includes tumors of the sympathetic ganglia and adrenal medulla that are derived from primordial neural crest cells populating these sites. Neuroblastoma is the most important member of this family. It is the most common extracranial solid tumor of childhood, and the most frequently diagnosed infant malignancy. The prevalence is about 1 in 7,000 live births, and there are approximately 700 cases diagnosed each year in the United States. The median age at diagnosis is 18 months. Approximately 40% of cases are diagnosed in infancy. Most neuroblastomas occur sporadically, but 1% to 2% are familial. In such cases, the neoplasms may involve both of the adrenals or multiple primary autonomic sites. Germline mutations in the anaplastic lymphoma kinase ALK gene, Chapter 13, are a major cause of familial predisposition to neuroblastoma. Somatic gain of function ALK mutations are also observed in approximately 10% of sporadic neuroblastomas. Despite the remarkable progress made in the therapy of this disease, long-term prognosis for high-risk subsets remains guarded, with 5-year survival in the range of 40%. As will be evident later, age and stage have a remarkable effect on prognosis, and, in general, children younger than 18 months of age tend to have a significantly more favorable prognosis than older individuals with similar disease burdens. 478 Chapter 10 Diseases of Infancy and Childhood. Morphology. In childhood, about 40% of neuroblastomas arise in the adrenal medulla. The remainder occur anywhere along the sympathetic chain, with the most common locations being the paravertebral region of the abdomen 25% and posterior mediastinum 15%. Tumors may arise in numerous other sites, including the pelvis, the neck, and within the brain, cerebral neuroblastomas. Neuroblastomas range in size from minute nodules, so-called in situ lesions, to large masses more than 1 kilogram in weight. In situ neuroblastomas are reported to occur 40 times more frequently than clinically overt tumors. The great majority of these silent lesions spontaneously regress, leaving only a focus of fibrosis or calcification in the adult. This has led some to question the neoplastic connotation for the in situ lesions. Some neuroblastomas are sharply demarcated by a fibrous pseudocapsule, but others are far more infiltrative and invade surrounding structures, including the kidneys, renal vein, and vena cava, and envelop the aorta. On transection, they are composed of soft, gray tan tissue. Larger tumors have areas of necrosis, cystic softening, and hemorrhage. Occasionally, foci of punctate intramural calcification can be palpated. Histologically, classic neuroblastomas are composed of small, primitive-appearing cells with dark nuclei, scant cytoplasm, and poorly defined cell borders growing in solid sheets. Such tumors may be difficult to differentiate morphologically from other small round blue cell tumors. Meiotic activity, nuclear breakdown, karyorrhexis, and pleomorphism may be prominent. The background often demonstrates a faintly eosinophilic fibrillary material, neuropil, that corresponds to neuritic processes of the primitive neuroblasts. Typically, Homer-Wright pseudorosets can be found in which tumor cells are concentrically arranged about a central space filled with neuropil, Fig. 10.23. Other helpful features include positive immunohistochemical reactions for neuron-specific enolase and the transcription factor PHOX2B. Some neoplasms show signs of maturation that can be spontaneous or therapy-induced. Larger cells having more abundant cytoplasm, large vesicular nuclei, and a prominent nucleolus. Figure 10.24 ganglioneuromas are characterized by clusters of large cells with eccentric nuclei, prominent nucleoli, and abundant eosinophilic cytoplasm, representing neoplastic ganglion cells, arrows. Spindle-shaped Schwann cells are present in the background stroma, representing ganglion cells in various stages of maturation, may be found in tumors admixed with primitive neuroblast ganglioneuroblastoma. Even better differentiated lesions contain many more large cells resembling mature ganglion cells with few if any residual neuroblasts. Such neoplasms merit the designation ganglioneuroma. Fig. 10.24. Maturation of neuroblasts into ganglion cells is usually accompanied by the appearance of Schwann cells. The origin of Schwann cells in neuroblastoma remains an issue of contention. Some investigators believe they represent a reactive population recruited by the tumor cells. However, studies using microdissection techniques have demonstrated that the Schwann cells harbor at least a subset of the same genetic alterations found in neuroblasts, and therefore are a component of the malignant clone. Irrespective of histogenesis, documenting the presence of Schwannian stroma is essential, because its presence is associated with a favorable outcome. See later. Metastasis, when they develop, appear early and widely. In addition to local infiltration and lymph node spread, there is a pronounced tendency to spread through the bloodstream to the liver, lungs, bone marrow, and bones. Staging. The International Neuroblastoma Staging System (INSS), which is the most widely used staging scheme worldwide, is detailed in Table 10.6. Unfortunately, most 60% to 80% children present with stage 3 or 4 tumors, and only 20% to 40% present with stage 1, 2A, 2B, or 4S neuroblastomas. The staging system is of paramount importance in determining prognosis. Figure 10.23 Adrenal neuroblastoma. This tumor is composed of small cells embedded in a finely fibrillar matrix neuropil. Several Homer-Wright pseudorosets are seen in this image. Clinical course and prognostic features. Table 10.7. In young children younger than 2 years of age, neuroblastomas generally present with large abdominal masses, fever, and possibly weight loss. In older children, they may not come to attention until metastasis produce manifestations, such as bone pain, respiratory symptoms, or gastrointestinal. Tumors and tumor-like lesions of infancy and childhood. 479. ELBA. Stage 1, Stage 2A, Stage 2. Tumors and tumor-like lesions of infancy and childhood. 479. And childhood. 479. ELBA. Stage 1. An important diagnostic feature, i.e., elevated blood levels of catecholamines and elevated urine levels of the metabolites vanillomandelic acid, VMA, and homovanillic acid, HVA. Despite the elaboration of catecholamines, hypertension is much less frequent with these neoplasms than with pheochromocytomas. Chapter 24. Ganglioneuromas, unlike their malignant counterparts, tend to produce either asymptomatic mass lesions or symptoms related to compression. The clinical course of neuroblastomas is extremely variable. Several clinical, histopathologic, molecular, and biochemical factors have been identified that have a bearing on prognosis. See Table 10.7. Based on the collection of prognostic factors present in a given patient, they are classified as low, intermediate, or high risk. With improvements in therapy, long-term survival exceeds 90% of patients in the first two groups, but less than 50% of patients in the high-risk category are long-term survivors. The most pertinent prognostic factors include the following: tumor stage and patient age at time of diagnosis. Neuroblastomas at stage 1, 2A, or 2B tend to have an excellent prognosis, irrespective of age. Low, or intermediate, risk tumors exhibiting amplification of the MYCN oncogene are a notable exception. Infants with localized primary tumors and metastasis to the liver, bone marrow, and skin, stage 4S, represent a special subtype, wherein it is not uncommon for the disease to regress spontaneously. The biologic basis of this welcome behavior is not clear. The age of 18 months has emerged as a critical point of dichotomy in terms of prognosis. Children younger than 18 months of age, and especially those in the first year of life, have an excellent prognosis regardless of the stage of the neoplasm. Children older than 18 months of age generally fall into at least the intermediate risk category, and those with higher stage tumors or with unfavorable prognostic features like MYCN amplification in the neoplastic cells are considered high risk. Tumor morphology. An age-linked morphologic classification of neuroblastic tumors has been proposed that divides them into favorable and unfavorable histologic subtypes. The specific morphologic features that bear on prognosis are listed in Table 10.7. MYCN amplification status. Amplification of the MYCN proto-oncogene in neuroblastomas markedly impacts the prognosis, particularly in tumors that would otherwise be classified as having a good prognosis. The presence of MYCN amplification bumps the tumor to the high risk category, irrespective of age, stage, or histology. MYCN is located on the distal short arm of chromosome 2, 2p23p24. Amplification of MYCN does not occur at the 2p23p24 site, but as extrachromosomal double minute chromosomes are homogeneously staining regions on Chapter 10 Diseases of Infancy and Childhood. Other chromosomes. Fig. 10.25. MYCN amplification is present in about 20% to 30% of primary tumors, most presenting as advanced stage disease, and the degree of amplification correlates with poor prognosis. MYCN amplification is currently the most important genetic abnormality used in risk stratification of neuroblastic tumors. See later. Ploidy of the tumor cells correlates with outcome in children younger than 2 years of age but loses its independent prognostic significance in older children. Broadly, neuroblastomas can be divided into two categories: near-diploid and hyperdiploid whole chromosome gains, with the latter being associated with a more favorable prognosis. It is postulated that neuroblastomas with hyperdiploidy have an underlying defect in the meiotic machinery leading to non-disjunction and whole chromosome gains, but otherwise relatively banal karyotypes. The more aggressive near-diploid tumors harbor generalized genomic instability, with multiple segment mutations. Wilm's tumor. Wilm's tumor, nephroblastoma, afflicts approximately 1 in 10,000 children in the United States, making it the most common primary renal tumor of childhood and the fourth most common pediatric malignancy in the United States. The peak incidence for Wilm's tumor is between 2 and 5 years of age, and 95% of tumors occur before 10 years of age. Approximately 5% to 10% of Wilm's tumors involve both kidneys, either simultaneously, synchronous, or one after the other, metachronous. Bilateral Wilm's tumors have, and tumor-like lesions of infancy and childhood. 481. a median age of onset approximately 10 months earlier than tumors restricted to one kidney, and these patients are presumed to harbor a germline mutation in one of the Wilm's tumor predisposing genes, see later. The biology of this tumor illustrates several important aspects of childhood neoplasms, such as the relationship between malformations and neoplasia, the histologic similarities between organogenesis and oncogenesis, the two-hit theory of recessive tumor suppressor genes, Chapter 7, the role of premalignant lesions, and perhaps most importantly, the potential for treatment to affect prognosis and outcome. Improvements in cure rates for Wilm's tumor, from as low as 30% a few decades ago to approximately 90% currently, represent one of the greatest successes of pediatric oncology. Pathogenesis and genetics. The risk of Wilm's tumor is increased with at least 3 recognizable groups of congenital malformations associated with distinct chromosomal loci. Although Wilm's tumors arising in this setting account for no more than 10% of cases, these syndromic tumors have provided important insight into the biology of this neoplasm. The first group of patients has the WAGR syndrome, characterized by Wilm's tumor, aniridia, genitourinary anomalies, and intellectual disability, formerly called mental retardation. Their lifetime risk of developing Wilm's tumor is approximately 33%. Individuals with WAGR syndrome carry constitutional, germline, deletions of 11p13. Studies on these patients led to the identification of the first Wilm's tumor-associated gene, WT1, and a contiguously deleted autosomal dominant gene for aniridia, PAX6, both located on chromosome 11p13. Patients with deletions restricted to PAX6, with normal WT1 function, develop aniridia, but they are not at increased risk for Wilm's tumors. The presence of germline WT1 deletions in WAGR syndrome represents the first hit. The development of Wilm's tumor in these patients frequently correlates with the occurrence of a nonsense or frameshift mutation in the second WT1 allele, second hit. A second group of patients at much higher risk for Wilm's tumor, approximately 90%, has Dennis-Drash syndrome, which is characterized by gonadal dysgenesis, male pseudohermaphroditism, and early-onset nephropathy leading to renal failure. The characteristic glomerular lesion in these patients is diffuse mesangial sclerosis, Chapter 20. As in patients with WAGR, these patients also demonstrate germline abnormalities in WT1. In patients with Dennis-Drash syndrome, however, the genetic abnormality is a dominant negative missense mutation in the zinc finger region of the WT1 protein that affects its DNA binding properties. This mutation interferes with the function of the remaining wild-type allele, yet strangely, it is sufficient only in causing genitourinary abnormalities but not tumorigenesis. Wilm's tumors arising in Dennis-Drash syndrome demonstrate biallelic inactivation of WT1. In addition to Wilm's tumors, these individuals are also at increased risk for developing germ cell tumors called gonadoblastomas, Chapter 21, almost certainly a consequence of disruption in normal gonadal development. Tumors. WT1 encodes a DNA-binding transcription factor that is expressed within several tissues, including the kidney and gonads, during embryogenesis. The WT1 protein is critical for normal renal and gonadal development. WT1 has multiple binding partners, and the choice of this partner can affect whether WT1 functions as a transcriptional activator or repressor in a given cellular context. Numerous transcriptional targets of WT1 have been identified, including genes encoding glomerular podocyte-specific proteins and proteins involved in induction of renal differentiation. Despite the importance of WT1 in nephrogenesis and its unequivocal role as a tumor suppressor gene, only about 10% of patients with sporadic non-syndromic Wilm's tumors demonstrate WT1 mutations, suggesting that the majority of these tumors are caused by mutations in other genes. A third group with an increased risk of developing Wilm's tumor consists of children with Beckwith-Wiedemann syndrome, BWS, characterized by enlargement of body organs, organomegaly, macroglossia, hemihypertrophy, omphalocele, and abnormal large cells in the adrenal cortex, adrenal cytomegaly. BWS has served as a model for tumorigenesis associated with genomic imprinting, Chapter 5. The chromosomal region implicated in BWS has been localized to band 11p15.5. So-called WT2 locus distal to the WT1 locus. This region contains multiple genes that are normally expressed from only one of the two parental alleles, with transcriptional silencing, i.e., imprinting, of the other parental homologue by methylation of the promoter region. Unlike WAGR and Dennis-Drash syndromes, the genetic basis for BWS is considerably more heterogeneous in that no single 11p15.5 gene is involved in all cases. Moreover, the phenotype of BWS, including the predisposition to tumorigenesis, is influenced by the specific imprinting abnormalities present. One of the genes in the 11p15.5 region, insulin-like growth factor 2, IGF-2, is normally expressed solely from the paternal allele, and the maternal allele is silenced by imprinting. In some Wilm's tumors, loss of imprinting, i.e., re-expression of the maternal IGF-2 allele, can be demonstrated, leading to overexpression of the IGF-2 protein. In other instances, there is selective deletion of the imprinted maternal allele combined with duplication of the transcriptionally active paternal allele in the tumor, uniparental paternal disomy, which has the identical functional effect of IGF-2 overexpression. Because the IGF-2 protein is an embryonal growth factor, it could conceivably explain the features of overgrowth associated with BWS as well as the increased risk for Wilm's tumors in these patients. In contrast with syndromic Wilm's tumors, the molecular abnormalities underlying sporadic, i.e., non-syndromic tumors, which account for 90% of cases overall in children, are only beginning to be elucidated. Some of them are associated with specific histologic features described later. For example, gain-of-function mutations of the gene encoding beta-catenin, Chapter 7, have been demonstrated in approximately 10% of sporadic Wilm's tumors. Other recurrent mutations occur in genes encoding proteins involved in microRNA mRNA processing, DROSHA. Chapter 10, Diseases of Infancy and Childhood. DGCR8, and DICER1, these are seen in 15% to 20% of Wilm's tumors with predominantly blasmal histology, see later. It is postulated that aberrations in mRNA processing lead to reduced levels of many mature mRNAs, in particular in the MIR200 family, which is involved in mesenchymal to epithelial transformation during renal morphogenesis. The lack of mesenchymal to epithelial transformation likely leads to persistent blastmal rests in the kidney, see the following, which evolve into Wilm's tumors. Finally, tumors with TP53 mutations are associated with an especially poor prognosis and often have a distinctive anaplastic histologic appearance, described later. Morphology grossly, Wilm's tumor tends to present as a large, solitary, well-circumscribed mass. Approximately 10% are either bilateral or multicentric at the time of diagnosis. On cut section, the tumor is soft, homogeneous, and tan to gray with occasional foci of hemorrhage, cyst formation, and necrosis. Fig. 10.26. Microscopically, Wilm's tumors are characterized by recognizable attempts to recapitulate different stages of nephrogenesis. The classic triphasic combination of blastmal, stromal, and epithelial cell types is observed in the vast majority of lesions, although the percentage of each component is variable. Fig. 10.27a. Sheets of small blue cells with few distinctive features characterize the blastmal component. Epithelial differentiation is usually in the form of abortive tubules or glomeruli. Stromal cells are usually fibroblastic or myxoid in nature, although skeletal muscle differentiation is not uncommon. Rarely, other heterologous elements are identified, including squamous or mucinous epithelium, smooth muscle, adipose tissue, cartilage, and osteoid and neurogenic tissue. Approximately 5% of tumors have anaplasia, defined as the presence of cells with large, hyperchromatic, pleomorphic nuclei and abnormal mitosis. See Fig. 10.27b. The presence of anaplasia correlates with the presence of TP53 mutations and the emergence of resistance to chemotherapy. Recall that P53, figure 10.26 Wilm's tumor in the lower pole of the kidney with the characteristic tan to gray color and well-circumscribed margins. Elicits pro-apoptotic signals in response to DNA damage. Chapter 7. The loss of P53 function might explain the relative unresponsiveness of anaplastic cells to cytotoxic chemotherapy. Nephrogenic rests are putative precursor lesions of Wilm's tumors and are seen in the renal parenchyma adjacent to approximately 25% to 40% of unilateral tumors. This frequency rises to nearly 100% in cases of bilateral Wilm's tumors. In many instances, the nephrogenic rests share genetic alterations with the adjacent Wilm's tumor, pointing to their preneoplastic status. The appearance of nephrogenic rests varies from expansal masses that resemble Wilm's tumors, hyperplastic rests, to sclerotic rests consisting predominantly of fibrous tissue and occasional admixed immature tubules or glomeruli. It is important to document the presence of nephrogenic rests in the resected specimen, because these patients are at an increased risk of developing Wilm's tumors in the contralateral kidney and require frequent and regular surveillance for many years. 482. Figure 10.27a Wilm's tumor with tightly packed blue cells, blastmal component, and interspersed primitive tubules, epithelial component. Although multiple meiotic figures are seen, none are atypical in this field. B. Focal anaplasia was present in this Wilm's tumor, characterized by cells with hyperchromatic, pleomorphic nuclei, and abnormal mitosis. Center, readings 483. Clinical features: most children with Wilm's tumors present with a large abdominal mass that may be unilateral or, when very large, extend across the midline and down into the pelvis. Hematuria, pain in the abdomen after a traumatic incident, intestinal obstruction, and hypertension are other patterns of presentation. In a considerable number of these patients, pulmonary metastasis are present at the time of primary diagnosis. As stated, most patients with Wilm's tumor can expect to be cured of their malignancy. Anaplastic histology is perhaps the most critical determinant of adverse prognosis. Even anaplasia restricted to the kidney, i.e., without extrarenal spread, confers an increased risk of recurrence and death, emphasizing the need for accurate identification of this histologic feature. Molecular parameters that correlate with adverse prognosis include loss of heterozygosity of chromosomes 1p and 16q, and gain of chromosome 1q in tumor cells. Along with the increased survival of individuals with Wilm's tumor have come reports of an increased risk of developing second primary tumors, including bone and soft tissue sarcomas, leukemia and lymphomas, and breast cancers. Although some of these neoplasms result from the presence of a germline mutation in a cancer predisposition gene, others are a consequence of therapy, most commonly radiation administered to the cancer field. This tragic, albeit uncommon, outcome has mandated that radiation therapy be used judiciously in the treatment of this and other childhood cancers. Suggested